Good morning, everybody. If you could all take your seats, we would appreciate it. We're ironing out some minor technical difficulties, and we'll start in just a couple minutes. wondering if it would make sense to come a little this way because this the speaker will kind of be yeah, and maybe oh yeah, that's better. That's better. Yeah, that's pretty good. Thanks. Okay, we're going to go ahead and get started. It's so great to see so many people in the room, and we have at least as many people watching at home virtually. So you're part of a very big community, and we're so happy to have you with us in person today. So this is the 23rd annual Parkinson's Disease Symposium. And we're grateful to Amanda Fessenden for all of her behind the scenes and also Heather Simpson for organizing. Amanda runs around a lot and organizes everything for us. And we thank North Central Baptist Church for letting us use their great facility. I want to give you just a little overview of how the morning is going to go. We're going to have several talks for you here in the room where we're all together, and then we separate into 2 tracks. We'll have a little break around noon with water and refreshments, and then we'll have in this room talks that might be of interest to people who have been here before or had Parkinson's a bit longer, or maybe anybody who wants to hear them. In the other talk, we consider that Parkinson's 101. Those will be some talks that may be topics related to the genetics of Parkinson's and related to non-motor symptoms. In this room, we'll be talking about medicines and surgeries for Parkinson's. Don't feel stressed that you make the right choice what room to be in because everything will be recorded. And probably within a couple weeks, we'll get it all online where you can find it and watch it after today. Even if you sit through a session and you go, wow, that was great, but I didn't catch it all, or I want my friend or my spouse or my child to see it, it's all going to go online where you can access it later. Watch it again and again if you want. So we're going to start our morning. We're just so delighted to have with us an international expert in Parkinson's, Dr. Ray Dorsey. Dr. Dorsey comes to us from the University of Rochester, and he's going to present a very interesting talk to everyone in this room, which is his belief that Parkinson's is a preventable disease and that exposures in our environment could be part of why so many people are getting Parkinson's. And he's going to share with us his thoughts about that. Welcome, Dr. Dorsey.
Good morning. Outstanding. I love it. It's Florida. I'm delighted to be here. Thanks to Irene for the very kind introduction. It's not my belief that Parkinson's is preventable. I think it's the fact. And I'm going to tell you a little bit about why Parkinson's disease is preventable, how you can prevent it for your children, how you can slow the progression, and maybe how we can get better treatments. But I thought I'd first start by saying why we're all here. So Dr. Michael Oken's been introducing me as his little brother. So my big brother is quite amazing. Not only is he an outstanding Parkinson's specialist, not only does he do a lot of research, not only is he one of the world's leaders in the surgical treatment of Parkinson's disease and other movement disorders, but he's a prolific writer. We've gotten to know Michael a lot for over the last 7 years as we've written a couple books together. But Michael on Amazon has like a whole library of books, and it's quite amazing what he's done. Many of you read several of these books. I've even read several of these books. Everything about new treatments for Parkinson's disease and those aimed at educating people like you. And then he educates people like me about the surgical treatments of the disease. And over the last 5 years or so, we've written 2 books, one called Ending Parkinson's Disease, and a second one coming out in August called The Parkinson's Plan. You have a chance to pre-order the Parkinson's Plan, and we will give you, if you pre-order the Parkinson's Plan today, we'll give you a free signed copy of Ending Parkinson's Disease later today. So how many of you know why you have Parkinson's disease? Why only a couple of you? So why is it important to know why you have a disease? You might have a clue how to treat it and help others avoid it. Exactly. So I think all of you would prefer that your children and grandchildren don't have Parkinson's disease. So if we figure out why you have Parkinson's disease, you can prevent your children and grandchildren, your brothers and sisters, your spouse from getting the same disease. And some of you know, to the extent that genetics plays a role in the disease, your children are 2 to 4 times increased risk. So if we find out what the cause is, we can make sure our children don't. That seems like a pretty fundamental obligation. Second is you can maybe slow the progression of the disease. I'll give you an example. If someone's a smoker and they go to the doctor and get diagnosed with lung cancer, what's the first thing the doctor's going to tell them to do? Stop smoking. But if you're a farmer using pesticides and you're diagnosed with Parkinson's disease, do we tell you to stop using pesticides? So maybe the reason some individuals with Parkinson's disease have a more favorable or slower rate of progression of disease is they stop getting exposed to the chemical that's causing their disease. And maybe some people who are having a more rapid rate, maybe it's because they're continuing to be exposed. And then third, how many want a cure for Parkinson's disease? Beautiful. So what's the prerequisite to curing a disease? What's causing it, right? It's really, really, really hard to cure a disease if you don't know what's causing it. And so some of you remember hepatitis C, right? And so hepatitis C a little before I went to medical school, was called non-hep A, non-hep B, because they weren't really sure what was going on. They thought it might be a virus. And then hepatitis C was a huge cause of liver cancer, huge reason why people had liver transplants. Maybe some of you have friends or family members with it. And then to our great astonishment, we can now cure hepatitis C with a pill. I'll give you another example. Some of you remember peptic ulcer disease, bleeding ulcers. What did they think bleeding ulcers was used to be due to? Stress. So they would tell you to quit your job, rest. And what did that do? More stress. So it didn't work. They would do surgeries. They would cut a nerve called the vagus nerve and do all these things to do it. What causes ulcers? Bacteria. What's the treatment? Antibiotic. Does anyone die from bleeding ulcers anymore? Right? All of you knew people who had bleeding ulcers, but now almost no one is dying of bleeding ulcers. So if we figure out what causes the disease, we can prevent it for our children, our grandchildren, our spouses, our brothers, our sisters, our friends, and our neighbors. We can slow the rate of progression of the disease, and we can ultimately get to a cure. So I'm going to tell you that Parkinson's disease is largely a man-made disease. It's due to chemicals in our food, water, and air, and it's eminently preventable. So in 1962, Rachel Carson, a biologist, wrote an outstanding book called Silent Spring. And in it, she didn't argue against the use of pesticides because she knew that pesticides can have enormous health benefits. And for example, DDT in World War II prevented thousands, if not millions, of people from getting malaria. But she was worried about the indiscriminate use of pesticides. So shortly after World War II, everyone started using DDT on everything. It was even sprayed on kids on beaches, and probably sprayed on kids on beaches here in Florida. And in her book in 1962, she said the farmers spoke of much illness among their families. In the town, the doctor had become more and more puzzled by new kinds of sickness appearing among their patients. And I think she's laying the seeds, obviously she didn't know, for Parkinson's disease. That Parkinson's disease, for example, is more common among farmers, and people who have indiscriminate use to pesticides are at increased risk for developing Parkinson's disease. So how many of you carry a genetic risk factor for Parkinson's disease? So I see one hand, two hands. So Parkinson's disease has very, very little to do with genetics, right? So 2 people in this room of 100, 200 people have identifiable genetic risk factor for disease. In fact, there's a scale that measures the heritability of diseases. It goes from 0, not heritable, to 1, perfectly heritable. And some diseases run in families. Type 1 diabetes, schizophrenia, and many mental illnesses run in families. But at the bottom of the list are diseases like Parkinson's disease and breast cancer. So Parkinson's is among the least heritable diseases. It has almost nothing to do with genetics. Almost nothing to do with genetics. And this is not my opinion, this is fact. So how many of you participate in the PD generation study or know about the PD generation study? So lots of people participate in the PD generation study. It's a study being done by the Parkinson's Foundation, a great study being also done here at the University of Florida. And it's asking people who have Parkinson's disease to participate in a study to assess if individuals with Parkinson's disease have a genetic cause or genetic risk factor for the disease. So you can imagine that this study might preferentially enroll people who have a family history of the disease, for example. And so they've done genetic testing on over 10,000 individuals with Parkinson's disease in North America. Over 10,000 people with Parkinson's disease in North America, including about 5 people in this room. Of that 10,000, 12.5% carry a genetic cause or genetic risk factor for the disease. Said another way, 87% of people with Parkinson's disease in North America have no known genetic mutation or genetic risk factor for the disease. Nothing. And this is exactly consistent with what Sir William Gowers, a British neurologist, said in late 1800s. He said only 15% of my patients have a family history of the disease. And even if you carry a genetic cause or risk factor for the disease, the majority of people with these genetic causes or risk factors do not actually develop the disease. So the most common genetic cause of Parkinson's disease is, is a mutation in a gene called LRRK2. Some of you have heard about this, but only about 30 or 40% of people with a LRRK2 mutation will go on to develop the disease. Said another way, there must be other factors to explain why some people who carry the most common genetic cause of the disease go on to develop the disease and why others do not. And so this was done in North America, and then our colleagues in Europe are doing a very similar study. They're doing genetic testing on people in the Americas, North and South America, and Europe and the Middle East. And they've identified that only 14% of people with Parkinson's disease carry a genetic risk factor or genetic cause for the disease. Some of you have been told that if you have a family history, you might be more likely to have Parkinson's disease. And indeed, if you have a family history of the disease, 20% of people have a genetic cause or risk factor. But 80% of people who have a family history of the disease have no known genetic cause or risk factor of disease. And it's because families not just share genetics, but they share environment too. Some of you have been told that if you have young onset Parkinson's, how many people have young onset before age 50? A couple, not many. That is due to genetics. But in fact, only 20% of people with young onset Parkinson's disease carry a genetic cause or risk factor for the disease. So Parkinson's disease is fundamentally not a disease of genetics. Parkinson's disease is a fundamental disease of the environment. So what are the environmental factors that's causing Parkinson's disease? I think there are 3 big ones, at least in the United States, and there are likely others in addition, but I'm going to focus on 3. One are certain pesticides, not all pesticides, but certain pesticides. The poster child for this is a pesticide called paraquat. Anyone work with paraquat? So paraquat. So paraquat is a weed killer developed in the 1950s, first used commercially in the 1960s. It kills the weeds that Roundup doesn't. It's so toxic that it's been used to commit homicide and suicide. It's associated with a 150% increased risk of Parkinson's disease. Over 50 countries, including China, have banned the chemical, yet paraquat is still used in the United States, still sprayed on farms here in Florida, widely used on fields of corn, cotton, soybeans, and vineyards. Second chemical is a chemical called trichloroethylene. This is one I'm obsessed with. It's so obsessed, I carry it with me everywhere I go. Many of you remember from chemistry that water is made up of 3 atoms, H2O, 2 hydrogens and 1 oxygen. Trichloroethylene is made up of a whopping 6 atoms, 2 carbons in black, 1 hydrogen in white, and 3 chlorines in blue, hence its name, trichloroethylene. It has a cousin, it's called perchloroethylene, which has 1 additional chlorine atom here. That chemical is widely used in dry cleaning. After this talk, you will not be using dry cleaners that use perchloroethylene. And these two chemicals, widely used in degreasing, decaffeinating coffee, and dry cleaning, are associated with up to a 500% increased risk of Parkinson's. When you feed it to laboratory animals, they develop the symptoms of Parkinson's. They have trouble moving, and they lose their nerve cells that produce dopamine. And the third one, maybe less important for this audience, is air pollution. When Dr. Parkinson described the condition, he described it in 1800 London, and air pollution was a huge issue. And we increasingly know that air pollution plays a role in many neurological diseases, especially Parkinson's and Alzheimer's. If you want to live a short, unhealthy life, you'll breathe polluted air. If you don't, you'll breathe nice, clean air and blue skies. And it turns out that air pollution is filled with something called particulate matter. So when you see smog on a hazy day, you're seeing little pieces of dirt and soot suspended in the air. And most of those pieces of dirt and soot we cough out or sneeze out. But some are so small that they can penetrate the nerve responsible for smell and make their way back to the smell center of the brain. And hitchhiking on those particles are toxic metals like lead from gasoline, iron from brakes, platinum from catalytic converters. And if you look at the brains of people with Parkinson's and Alzheimer's disease, you see high concentrations of metal in the brain, and we don't have a good explanation for why that is. In addition, the pathology of Parkinson's and Alzheimer's for most individuals begins in the smell center. And many of you know one of the earliest features of both diseases is loss of smell. So in many cases, I think these toxicants we're breathing in are contributing to the rise of Parkinson's disease and to some of its early symptoms. So this is a paraquat. This is a map of where it's sprayed according to the U.S. Geological Survey. And it's widely sprayed. It kills weeds. It's highly effective for killing weeds, but both laboratory studies and epidemiological studies in humans have demonstrated a strong association, and in laboratory studies, causation of paraquat and Parkinson's disease. But it turns out what academic scientists and academics like Michael and I know pales in comparison to what the company knew about its product. There have been lawsuits against the manufacturer of paraquat because farmers in different parts of the country, especially in the Central Valley of California, have been developing Parkinson's disease after exposure to paraquat, after working for it, years later developing Parkinson's disease, and have been suing the company. Reporters from The Guardian, including Ms. Carrie Gillum, have been reviewing the legal documents that the company's having to file in their defense. And it turns out that the company knew quite a bit about their product for many years, according to The Guardian. In 1962, it was introduced as a weed killer in the United Kingdom first, and then the United States. The United Kingdom has since banned the chemical, but still exports it to the United States. In 1964, the company found that skin exposure to paraquat in rabbits caused weakness and incoordination. In 1966, they found that large doses of paraquat in some rats and mice result in a stiff gait or tremors. So the manufacturer of paraquat, which is still sprayed on farms today, including in Florida, knew 60 years ago that exposure of their weed killer in 3 different mammalian species produced the features of Parkinson's disease. They knew this a generation before academic researchers reached the same conclusion. 50 years ago, regulators were concerned that workers might inadvertently lick small quantities of paraquat residue off their lips or inhaled paraquat mist. Rumors circulate that some in the EPA favor banning paraquat. Despite lawsuits supported by the Michael J. Fox Foundation, the EPA has yet to ban paraquat. Paraquat is manufactured by a company, I think, owned by a firm in China. China refuses to spray paraquat on its farms, but the United States imports paraquat and sprays it on ours. In 1976, a brain autopsy showed degenerative changes in the cells of the substantia nigra. For those of you not familiar, that's exactly what you see in Parkinson's disease, is loss of nerve cells in a part of the brain called the substantia nigra. And in 1985, a Canadian neurologist named Dr. Andre Barbeau was concerned about pesticides being sprayed in rural parts of Canada. So he looked at the the amount of pesticides sprayed in rural parts of Canada and the rates of Parkinson's disease, and he found a near perfect correlation between pesticide use and Parkinson's disease. The company became aware of the study and warned in an internal memo that paraquat-like asbestos could become a huge legal liability as Parkinson's can go on for decades. So I didn't know any of this at all. And I shared this with one of my colleagues, a friend who's an English professor at the University of Rochester. And he said to me, Ray, this is agnotology. And if you're like me, I was like, what in the world is agnotology? When he goes, Ray, science is the production of knowledge, ideally for the public's benefit. Agnotology is the deliberate production of ignorance, often for corporate gain. And it's the same thing that the tobacco companies have done in the past. You know, they used to have doctors like me be advertising the health benefits of cigarettes. We've seen that with the opioid pandemic. When Michael and I were in medical school, we were taught erroneously that individuals in acute pain could almost never become addicted to opioids that were prescribed. We've seen this with social media, where the companies, according to the Wall Street Journal, who produce social media knew about its adverse effects on the mental health of teenagers, especially girls, yet have continued to promote its use. And if this is being done to paraquat and Parkinson's disease, it begs the question, what other chemicals are we ignorant of that are contributing to Parkinson's disease? And then what other chemicals are we ignorant of that are contributing to other medical conditions? So trichloroethylene is this widely used degreasing, dry cleaning, and even used in decaffeinating coffee in the 1970s. If you drank decaffeinated coffee in the United States in the 1970s, you might have been drinking trichloroethylene until the FDA banned its use in 1977. And this was a widely used degreasing agent. It's estimated in 1970 that 10 million Americans worked with the chemical. In England, 1 in 12 workers worked with trichloroethylene. And this is just a partial list of occupations that are associated with possible exposure to TCE. So aircraft or jet engine mechanics, I was speaking to a mechanic earlier this morning, automobile workers, dry cleaners, electronic manufacturers. It was widely used in Silicon Valley to remove residue off silicon wafers, used in embalming, oil processors, painters, printers, refrigerant manufacturers, shoemakers, taxidermists, varnish workers. And then it had a wide use of commercial and consumer uses. Speaking to one of my colleagues yesterday, who might have been exposed to it in its use as a gun cleaner, but it's used to clean guns, carpet cleaners, decaffeinating coffee, paint and paint removers, pepper spray, refrigerants, even in typewriter correction fluid. Those of you who are young enough remember typewriter correction fluid and wood finishes. And it's had a wide use of industrial and military uses. It was even used to anesthetize patients. This is from one of my, the father-in-law of one of my friends who's an obstetrician. This is an article he shared with me from the American Journal of Obstetrics and Gynecology, in which Dr. Flowers wrote, trichloroethylene, or TCE as it's commonly abbreviated, is a potent analgesic drug. Its margin of safety and ease of administration will ultimately make it a standard agent on all delivery floors. Trichloroethylene's wide variety of uses will probably allow almost every obstetrician to find a place for it in his obstetrical practice. So women were encouraged to self-administer TCE to reduce pain, and then they would drop the canister. Some of you might be wondering whether pregnant women from this era are increased risk of Parkinson's. I couldn't find out, but there is actually a study suggesting that anesthesiologists from this era might have an increased risk of having Parkinson's disease. My colleagues, Drs. Caroline Tanner and Sam Goldman at the University of California, San Francisco, did a landmark study over a decade ago and looked at veteran twins from World War II. And they looked at twins who either had hobby or work exposure to TCE versus twins who didn't. Those who did had a 500% increased risk of developing Parkinson's, not a 5%, not a 15%, not 100%, a 500% increased risk of developing Parkinson's disease. Importantly, they showed you don't get exposed to TCE and develop Parkinson's disease the next day. There's a lag, just like you don't smoke a cigarette in your 20s and develop lung cancer the next day or the next month or next year. It's decades later. The same happens with Parkinson's disease. And because TCE is so widespread use, my colleagues wrote that the potential public health implications of these results are substantial. Yet even people like me were wholly unaware of this until I had the gift of a sabbatical and I started reading all of their papers. But TCE in Parkinson's disease is actually one of its lesser health concerns because TCE is known to cause cancer. It's not my opinion. This is the conclusion of the World Health Organization. This is the conclusion of the Department of Health and Human Services. And this is the conclusion of the Environmental Protection Agency, which says that TCE is carcinogenic, a fancy word for says causes cancer in humans by all routes of exposure, whether you come into contact with your skin, whether you drink it through contaminated water, or whether you inhale it. And TCE is associated with increased incidences of liver cancer, kidney cancer, non-Hodgkin's lymphoma, prostate cancer, multiple myeloma. And we know, for example, that people with Parkinson's disease seem to have higher rates of prostate cancer, for example. TCE is also associated with leukemia, especially in children, brain cancer, and likely breast cancer. If you have worked with TCE or have stories, I'd love to hear. I'd love you to come up and tell me about them because this is how I learn. And it turns out that the increasing rates of cancer, that cancer rates in the United States are increasing, especially for people under 50. So in the United States, which spends more on healthcare than any other nation by far, in fact, we spend more on healthcare than the entire continent of Europe does, cancer rates under 50 are increasing. So this is unlikely to be genetics because genes don't change that much in just a few generations. It's not due to aging because this is happening in young adults. And it's unlikely to be done due to screening because generally we don't screen for cancers until people become 50. Yet in the United States, cancer rates are increasing for people under 50. At the same time, we're smoking fewer and fewer cigarettes than ever before, which begs the question of why. Diseases don't just happen by accident. Diseases have causes. There are reasons why people develop diseases. Which brings me to Camp Lejeune. So how many of you heard about Camp Lejeune? Perfect. So Camp Lejeune is a Marine base in Wilmington, North Carolina. It's one of the two major Marine bases where Marines like, can I say Dr. Hess? Yeah, like Dr. Hess, trained. And from 1953 to 1987, the drinking water at the Marine base was contaminated with TCE. It was contaminated from a nearby dry cleaner because the officers at the military base needed to have dry cleaned and cleaned and pressed uniforms. And there was a dry cleaner from which the chemical contaminated the drinking water. And there were other sources of contamination as well. And Doctors Tanner and Goldman, who did the study, and the twins from World War II, have studied service members who served at Camp Lejeune between 1953 and 1987. The study was done people who served in the 1970s, and found that Marines who served at Camp Lejeune had a 70% increased risk of developing Parkinson's disease compared to Marines who served at Camp Pendleton in California. A 70% increased risk of Parkinson's. Like their previous studies, they found that the average lag time between the diagnosis and development of the disease was 33 years. The Marines, almost by definition, were healthy, right? So to become a Marine, you have to be healthy. You're young, the average age was 20, and you're not at a Marine base for very long. So on average, they were only at the Marine base for 2 years. Yet 35 years later, they're developing Parkinson's at 70% increased risk. And this cohort is young. The average age of the cohort is only 60 years old. So in the future, when this cohort gets to 65 to 70 to 75, there are likely to be additional cases of Parkinson's disease. Among the tragedies of all this is that the Marines knew about the contaminated water, yet did nothing about it, and actually even refused to notify Marines of their exposure to the contaminated water after they became aware of it until Congress made them do so. And as they concluded in their study, millions worldwide have been and continue to be exposed to this ubiquitous environmental contaminant. And so you may be saying, I wasn't a Marine, I didn't serve in the military, or I didn't serve at Camp Lejeune, I didn't degrease metals, I didn't work in the automobile industry, wasn't one of those 10 million people. How could I have been, I wasn't exposed to TCE? And I might say, hold on, because TCE is one of the most common environmental contaminants. So many of you know about forever chemicals and their contamination of water. Turns out that up to 30% of groundwater in the United States is contaminated with trichloroethylene. So how does this happen? Well, sometimes it leaks from sewer lines. Sometimes it leaks from underground storage tanks. Sometimes companies or dry cleaners or military bases dispose of it inappropriately, and it gets it down into the soil. And then, depending on where you live, 15 to 50 feet below the surface, probably less in Florida, is groundwater. And once TCE makes its way down to the groundwater, it can form concentrated pockets of it and can form plumes that will then migrate with the groundwater. And these plumes can move up to a mile or more away. And many of you know that radon can evaporate from the soil and enter your basement, for example, and can cause lung cancer. Well, TCE can evaporate from groundwater or soil and enter your home, your kid's school, or your workplace and breathe it in undetected. And so in Rochester, we investigated a cohort. One of my friends is an attorney, and I asked him one day, hey, Dan, why did you get Parkinson's disease? And he goes, I don't know, but does not begin.
Okay, let's move on.
So in 2003, during that support not in the brain. Says when I look at the brain in individuals with Parkinson's, I see the pathology even in the nose, right behind the nose, and the brain where I see.
There we go. There we go.
The video. And he thought that like polio, which is spread by drinking or eating contaminated, drinking contaminated water, I might be in the gut. And then spread upward.
Click on it.
Oh, there we go. There we go. That polio, the gut, to the parts of the brain that control sleep and control our blood pressure.
Why am I
and
not?
parts of the brain that control movement.
Spotlight for everyone. There we go.
In 2019, Dr. Fairport, our colleagues in.
As Heather took over because I detached.
We buy the body first. That begins in the gut and spreads upwards. And then there's a brain first, nose first model disease where the pathology begins in the nose and spreads backwards.
Let's see, YouTube live.
The movement. So I read all of this great. I had them all up in the living room.
Yeah.
And then I emailed them and said,
It's a
you know,
couple
this
seconds
seems
behind,
like
but
a
it's
great model for explaining chemicals that we either.
No, I'm replying as my gaming account. Probably shouldn't do that. Okay.
So we wrote this paper, hypothesis paper, we figured that indeed chemicals that are swallowed or ingested by the movie that are in between might have Parkinson's in the gut. They might have early constipation, early
I
problems
think I
with
can
blood
switch
pressure,
accounts to
early
my
problems with sleep disturbance.
more professional looking way.
And we tend to have a more symmetric form of Parkinson's because the gut gets innervation from both sides of the body. Or people might inhale the chemical on one hemisphere. They have asymmetric Parkinson's, but one side more than the other. They have early motor features of the disease and only later get problems with sleep, only later get problems with complication, and only much later get significant problems with thinking.
This is good.
Next slide.
Your thing should work.
No, it shouldn't.
Perfect. So not.
Yeah, but well,
It has to be active.
Preventable, which you guys already know, but
Nope.
next slide. So this is my report card, I think. It turns out that Parkinson's is one of the world's fastest growing brain. And so this has all happened in 1990s when I graduated high school. So all this has been happening on my watch. And if I'm such a smart guy, shouldn't I be doing something to prevent people from getting Parkinson's? And my colleagues in the HIV community have woken up and addressed HIV, and lots of us don't get HIV because they have woken up and changed the course of HIV. During the COVID-19 pandemic, our colleagues in infectious disease responded and prevented lots of us from getting COVID-19. Stroke is actually decreasing because we're now preventing stroke. We're smoking less, we're taking better control of our blood pressure and our cholesterol, and we even have better treatments. We're not. The status quo is failing. And that's evidenced by all the people in this room, that's evidenced by all the people on Zoom, and that's evidenced by the fact that 200 Americans were diagnosed with Parkinson's yesterday, and 100
It should be fine now.
died.
Order it if I can.
But there's a great story
You advance that.
that if we know what.
Because we told them it's working.
There are some parts of the world, especially in Europe, where the incidence percent after adjusting for age, a 60% drop in the incident number of new cases of. And the authors didn't have a good explanation for why. So I went backwards and I said, let's look at the three things I'm most concerned about: pesticides. And it turned out between 1968 and 1986, the levels of DDT, which are fat loving, dissolving fat, dropped in the fat tissue of the Dutch population between 75 and 90% in just 2 decades. They got rid of DDT, and DDT plummets in people's fat tissue. Turns out in 1981, the Netherlands had the lowest level of TCP in their outdoor air of any country in Europe, or one of the lowest. And it turns out that in the decades preceding rapidly improved in Western Europe, it's rapidly improved in the United States, except for the Canadian wildfire. And then 20 years later, you see a 60% drop in disease. You get rid of Parkinson's disease. You do not have chemical exposure to these chemicals. I don't think you develop Parkinson's disease for the vast majority. Next slide. So I think we create a world without Parkinson. Next slide. So one of the books I did show you that Dr. Michael Oken wrote was his first. It's Lessons from the Bedside. It is little stories that when he was note cards, when he was a medical student, he put them into his dirty white coat, and then later transcribed them into a book that's available on Amazon. And I read a little bit of it, and it's quite good. And it clearly taught us that we need to be and one of the first stories in the book, he's like, pain, like all other emotions share. Pain never really disappears, but fades away. Remember that other people's pain is also your pain. So the reason I'm passionate about this is because Parkinson's disease sucks, right? This is what Michael J. Fox says multiple times in his books and interviews. Parkinson's disease sucks. And although no one in my immediate family has Parkinson's disease, I didn't grow up with a grandmother with Parkinson's disease, I know how bad it is. And so when I see people walking on the Erie Canal in Rochester, when I see people in the airport with Parkinson's disease, when I see people walking the streets of Gainesville or wherever it is with Parkinson's disease, I get pissed off. I get pissed off because I know Parkinson's disease is bad. I know that they're suffering, and I know what the future holds for them. I know what the future holds for them and their loved ones. And if we can prevent Parkinson's disease, I can't think of a more fundamental responsibility for us to do so. Next slide. So my son is a budding philosopher, and I'll tell you 2 stories. One, when he was in high school, driving the car, and he goes, "Dad, between epistemology and metaphysics." So he did. And then he goes, "Dad, do you know who Derek Parfit is?" And I go, he said, "It's beautiful now." Remember about polio, right? And so many of you know that we live now in a world that's largely free of polio because of a march of dimes, because ordinary people like you in Gainesville, Florida, banded together, raised money for polio research, identified what its root cause was, identified that it was a virus, and then March of Dimes was began, and Jonas Salk announced the vaccine. Dr. Albert Sabin, and we live in a world that's largely free of polio. There are no polio treatments, polio support groups. There's just no polio. In 1980, the daughter of Candace Lightner, a 13-year-old daughter, was struck by a drunk driver, a car driven by a drunk driver, and was literally knocked out of her shoes and died. 4 days after Ms. Lightner lost her daughter, she begins lobbying the state legislature in California to take actions to reduce drunk driving. In 1980, when her daughter died, drinking and driving was actually legal in some states in the United States. Every day for a year, she went to the governor of California's office, then Jerry Brown, and petitioned to change the laws. 8 years later, drinking and driving is illegal in all 50 states. The drinking age is raised from 18 to 21. Blood alcohol levels dropped to 0.08. Today, 10,000 fewer people die from drinking and driving accidents than they did in 1980. In fact, that's happened every year since 1988. That's 10,000 children not killed, 10,000 families not torn apart, 10,000 communities that don't grieve. And many of us are alive today because of the works of Candace Lightner. In New York City and in San Francisco, and a man by Larry Kramer, who was a playwright, formed an organization. ACT UP was silence equals death, because for HIV in the 1980s, if they didn't make their voices heard, they died. And for people with Parkinson's disease, if we don't make our voices heard, we don't die, but we just suffer, right? And we suffer a lot. And because of the actions of Larry Kramer and his colleagues, 8 years after they life expectancy, more people with HIV, a great portion of people with HIV are appropriately treated for their condition than Parkinson's disease. It's preventable with a condom. The incidence of HIV in the world is at its lowest level. As a major clinical entity in our lifetime if we continue to do the good work that they have started. So we've inherited a world where polio is largely non-existent. We've inherited a world where drinking and driving is socially unacceptable. And we've inherited a world where HIV is both preventable and treatable. These are gifts that we've received from previous generations. You have an obligation to receive a gift, and you have an obligation to reciprocate. But we're going to need to act to change the course of Parkinson's disease. And that was the central message of our first book, Ending Parkinson's Disease, that if we found our collective voices, if we made enough noise, that if we came together like we're doing today in a church, we could change the course of Parkinson's disease, not just for our generation, but for all generations to come. And if we do so, if we identify what the root causes of the disease, we can prevent it, we can slow its progression, and we can eventually develop a cure for it. So in our book, our next book, we come up with the Parkinson's 25 things that you can do to slow the rate of progression of Parkinson's disease, and 25 things your children, your spouse, your brother, your sister, your neighbor, your friend can do, your enemy can do to not develop Parkinson's disease. And so it starts off with some simple ones like washing your produce, even your organic ones, because we know that food has residues of pesticides on it. It talks about changing your diet, just like you heard earlier today, that the Mediterranean diet, high in fruits and vegetables, low in animal products, might be helpful. I don't think it's helpful because of the nutrients of the fruits and vegetables, but I think it might be helpful because as food makes its way up the food chain, that animals might have higher levels of these fat-loving chemicals in their tissues, and then that we eat those tissues, and then they get concentrated in our body further. We talk about making sure that your grocery store is not located near dry cleaners, because dry cleaners, that chemical is also fat loving. And that in German grocery stores located next to dry cleaners, when you eat the butter and the cheese from those German supermarkets, you are eating TCE and PCE. And then we talk about enjoying your wine without pesticides, because a study done in France showed that almost every bottle of wine that they tested in France had residues of pesticides in them. And we need a plan. We need a plan to prevent Parkinson's disease for future generations. We need a plan to prevent Parkinson's disease for this generation, and we need a plan to treat this disease. And so one of the great accomplishments of last year was the passage of the National Plan to End Parkinson's Disease. This was supported. Two of its chief sponsors were Congressman Gus Bilirakis from here in Florida and Congresswoman Jennifer Wexton from Virginia. Congressman Bilirakis' family has Parkinson's disease, and Congresswoman Jennifer Wexton has a rare Parkinsonian disorder called PSP, or progressive supranuclear palsy. This bill, which passed the House 407-9, chief sponsor was a man and a woman, a Republican and a Democrat, someone who's had family members affected by the disease, and someone who's been directly affected by the disease. This bill unanimously passed the Senate and was signed into law by President Biden. If we can come together, we can develop a plan, for the first time, a federal plan to prevent, treat, and cure Parkinson's disease, but we need to act. I like to read, as you probably gathered, and I was introduced to Susan Sontag. Anyone know Susan Sontag? So the late writer from New York City, she wrote this great book on photography, and she's got this great line, and it's, be serious, be passionate, and wake up. And I don't think we've been serious enough. I certainly don't think we've been passionate enough about Parkinson's disease. I mean, think about what people with HIV did. They developed a quilt to cover the National Mall. I mean, they barricaded themselves in the streets of New York. They overtook the New York Stock Exchange. They overtook the FDA. We have not found that voice for Parkinson's disease. And because we have not found that voice, more and more people are suffering. And we need to wake up. Parkinson's disease is not fundamentally a disease of aging. You don't put a mice in the laboratory and sit it there for 20 years and it spontaneously develops Parkinson's disease. The only way that mouse is ever going to develop Parkinson's disease is if we manipulate its genes or exposure to toxic chemicals. And Parkinson's disease has very little to do with genetics, as I've discussed here. Parkinson's disease is fundamentally a disease of our environment. It's due to chemicals in our food, water, and air. So what should we do? I think we should resolve here on the 23rd annual gathering of this organization that 10 years from now, in 2035, that the incidence of Parkinson's disease is no longer rising, but falling. That the incidence of Parkinson's disease in Florida, in the United States, and around the world begins to fall in 10 years. We saw what we can do in the Netherlands with a 60% decline over 20 years. What can we do in Florida in 10 years? And then on the 46th anniversary of this organization, we should be planning for its demise. The March of Dimes no longer invests in polio because polio has been taken care of. We should take care of Parkinson's disease. Thank you very much. Turn it over to Irene.
So I think we all agree that was just an outstanding and very thought-provoking talk, a call to action. Dr. Dorsey's going to stay around at the lunch hour, which is at 12:45 to 1:30. We're going to have an Ask the Expert panel, and Dr. Dorsey will be there. So you probably have questions. You may have follow-up questions, and we will have a panel of experts. On your table, there are papers, so you can write down any questions you have that you don't want to forget. And we have some beautiful young volunteers. Dr. Adolfo Ramirez's daughters and mine are going to come around and collect those papers and bring them up to the panel. So please don't hesitate to save your questions. Another important thing for you to know are that there are bathrooms both outside of these doors and around the corner and just outside of these doors. In the front here, there's also a family bathroom if anyone needs to assist another person, that's available. And when we have our break, feel free to visit the tables here. Dr. Dorsey has kindly offered, as you heard, to give away his already published book with Dr. Oken, Ending Parkinson's Disease, to everyone who plans to get the next book. So we're really happy, and he'll sign and autograph the book for you. So our next talk is our very own Dr. Christopher Hess, who's going to talk to us about communicating with your doctor and making the most of your clinical visits.
All right, good morning, everyone. As you heard, my name is Christopher Hess. I'm one of the movement disorders neurologists here. Let's see if we do have control over the slides. So thank you all for joining us today, and thank you to Dr. Dorsey for a really thought-provoking talk. So we're going to be changing gears a little bit now and focusing on communicating with your doctor and making the most of your clinical visit. It's going to be about a half an hour, and I'm going to be talking with you about some tips and tricks and ways to approach the process of seeing your doctor regularly. Okay, so this is a cartoon that was made by one of our prior movement disorders fellows based on a conversation and an analogy I often have with my patients. And so I'll often talk to patients and say, we're all on our journey, right? We're all on our journey through life. On that journey, sometimes you get surprised by the roads that you take. Sometimes you know exactly where you're going. You have friends and family in the car on the journey with you. And when you get diagnosed with Parkinson's disease, you often find that you have this unwanted passenger with you, right? They're going to be with you for the rest of the journey. Right now, we don't have a cure for Parkinson's disease. We don't have a way to reverse it. And so you have this unwanted passenger, and you can sometimes, when you're having a tough time, they are right up there in the front seat next to you. And other times when things are sort of average, they're in the back seat. And sometimes when things are going really well, they're in the trunk and they're knocking for your attention, right? But for the most part, it varies. And so your job as a patient with Parkinson's disease, and our job as well, is to make sure that Parkinson's is not in the driver's seat. And that's really going to be a focus of my talk today, specifically with regard to making the most of your visits with your doctor, because it's a very valuable time. Okay, so I'm not going to spend too much time on finding care, but everybody in the room is somewhat lucky in that they are within driving distance of a major movement disorder center. Throughout the United States, that is not the case. So about 40% of patients with Parkinson's disease throughout the United States are getting their Parkinson's disease care from their primary care doctor. And we know from studies that that is not ideal. Only about 10% of patients across the United States are getting their movement disorders care from a movement disorders expert, right? So we're all movement disorders neurologists. This is all we do. General neurologists, they have to treat epilepsy, they have to treat MS, they have to be sort of a jack of all trades. We have the luxury of focusing just on you. And so it's the minority of patients who have the luxury of being able to be seen by a movement disorders neurologist. And there's a lot of people that are tuning in remotely from across the US today. And the information I wanted to convey to them was, if it is at all possible, you definitely want to try to get your movement disorders care from a neurologist. If you're able to get access to a movement disorders neurologist, that's terrific. Again, only 10% of patients are able to. There's not that many of us out there. And so if you are getting your care from a primary care doctor, you might have a great primary care doctor, but they have to be good in everything, and they have to know who to send you to and when to send you. And so it's really important to try to, at a minimum, get your care from a neurologist. And if you have access to a movement disorders neurologist, that's terrific. Does anybody want to guess Every year we have our graduating fellows. So we have a large movement disorders program here. Does anybody want to guess how many newly minted movement disorders neurologists were sent out into the world last June? Okay, so I heard a whole bunch that range from 170 to 1. So 67. 67 movement disorders neurologists graduated last year for the entire United States. And that's actually better than a decade before that when it was in the 30s. So again, really a luxury to be able to be seen by a movement disorders neurologist. And if you have access to that, you want to really make the most of your visit because that's your time. And one of the best ways that you can stay in the driver's seat with regard to your life is to stay in the driver's seat with regard to getting your Parkinson's care. Okay, so now we're going to move into some tips, right? So we have our Boy Scout on the side here. His motto is be prepared, right? Be prepared. And then we've got Mike Tyson on the other side. And his famous quote was, everybody has a plan until they get punched in the face, right? But nobody's going to be punching you in the face at your visit. So you don't have to worry about that. Your plan that you put together ahead of time will be valid, right? So when you go to your movement disorders visit, you think to yourself, okay, I'm going here because they're going to monitor my symptoms, or I'm going because they're going to fix my problem. And all those things are things that we try to do throughout your movement disorders visit. But what you're really doing is you're going there for a fixed period of the expert's undivided attention. And if you're at a center like ours, that can be for a half an hour for a follow-up patient and for an hour for a new patient. And if you're in a private practice, sometimes that's only 10 or 15 minutes. But it's very, very valuable time. And what you want to do is you want to make it as easy as possible for the person providing your care to make decisions in that fixed period of time, right? So any deviations from the ideal with regard to transmitting information back and forth, with regard to preparedness, is going to take away from the time that we can spend coming up with a plan to improve your lives. And that's what we want to do, right? If we could clone us and send each one of us into each one of your houses, we could manage your Parkinson's very well. But obviously that's not possible. And so it's very, very important to think of your visits that way. You want to think of it as, how can I maximally allow my provider to help me during that visit? And it's all about preparation and having a plan. So one of the most important things that you can do is bring your partner. Sometimes patients will prefer to have their partner wait in the waiting room, and there are personal reasons for why that might be. But for those of you who do have your partner with you in your clinical visits, there's a tremendous benefit to that. And it's for a couple of reasons, right? So one is, you don't remember everything that's been happening to you. You don't remember everything that's happened over the course of the time since the last time you were there. They are another source of information that you can lean on when you're not quite sure of an answer. For many of you, your partner is the pharmacist. They run the medications, right? You're just following the plan. So having them with you allows access for the provider to know exactly what you're doing. And also they see a different aspect of your Parkinson's disease than you do. So when you're caring for someone with Parkinson's disease, you have a lot of experts. You have the patient who's actually an expert in what they're feeling. They're going to know what they're feeling to a much better degree than I ever will. And their partner or their family member is looking at it from the outside, and they're seeing things that I'm not seeing and that the patient isn't seeing, or that you're not seeing. And so everybody brings this area of expertise, and it's really, really important to make use of that because it can be very valuable to have your partner's input. So I always recommend bringing your partner with you. Okay, managing your own medical records. So there's a very famous quote by Ben Franklin that says, "In this world, nothing can be said to be certain except death, taxes, and your doctor's office misplacing your medical records." So I might have changed that quote a little bit, but the point here is that there are thousands of records going back and forth in doctors' offices, right? Every day, faxes are coming in, records are going out. There's only one of you. And in an ideal world, you should be able to sit back and not have to worry about the records, and it would always get to where it's supposed to go, but it just isn't reality now. So what I recommend that all of you do, if you're seeing a new doctor, you want to make sure that you go to that physician with a copy of your own medical records. So it's great to have a doctor and say, please send my records to X place, right? And then you've got a chance of them losing it when they send it. You've got a chance of them losing it or misplacing it when they receive it, or you've got a chance of it being there, but just in a pile of other records that just haven't been processed yet. If you get your own records and you bring them to an office and you say, here are my records, copy them, please, but then give them back to me, you maintain control over that data, and you can bring it to any doctor that you want. And it's the same thing with any imaging studies that you get done. So if a primary care doctor or a private neurologist in the community orders an MRI of your brain, they are going to get back a report that describes what the radiologist thinks. When we order a study, we care what the radiologist thinks, but we want to see those images ourselves. And so whenever you get a study done, I always recommend getting your own copy of the disc, right? And when you do that, you can bring that disc to us and you can say, here's my MRI. Make a copy of it, but then give it back to me. And you always maintain control of your own medical records. This is a way to make sure that when it comes to your own care, you are staying in the driver's seat. Okay. So this is kind of a joke, obviously. We are very embarrassed by how often we run late. But it is really important to plan ahead because we all know getting out of the house when you have Parkinson's disease can be difficult. You never know if there's going to be a bathroom issue. If there's even a little bit of traffic, it's going to worsen your Parkinson's symptoms as you stress about it. And if you are even 3 minutes late for a 30-minute appointment, you've lost 10% of your time, right? So you bring a book, bring an iPad, bring something and leave early enough to where during that 30-minute period of time, I'm going to do everything I possibly can to help you within that period of time. And if I can go over a little bit, I will. And sometimes that's why we're late. But in the end, it's going to be up to you to make sure that you're making use of that full amount of time. So it's really, really important for you to be there on time. And we do the best that we can to try to start on time. Now, that being said, a lot of you have had that experience of being in the waiting room and waiting and waiting and waiting. And so as you can imagine, life happens to people, right? So if we are seeing patients and each patient each day takes 6 minutes to either get in the room or there's a delay or someone has to use the restroom, you take that 6 minutes and you multiply it by 12. And you can imagine if you're the last patient of the day, how far we are running behind. Not because we came late, not because we stopped for a coffee or something, just because we're doing the best that we can to keep up. And so every time we come in the room and we're 30 minutes late or 45 minutes late or even sometimes an hour late, we're mortified and we're embarrassed and we wish that wasn't the case. We respect your time, but we're doing the best we can. And the only thing that I can say in those situations is just try to keep in mind, if we find a situation where you're the person who needs that extra time, we will give it to you the same way that someone before you might have needed that extra time. Show your hand. Okay. So if you see your provider for Parkinson's disease and you have a form for them to complete, or you have paperwork that you've completed, or maybe you're involved in a research project and you have completed a questionnaire, or maybe you have new records that need to be added to your medical record at that center. You don't want to wait to the last 5 minutes, right? If a doctor, so when we come in the room, it's almost like a battle plan. We know what the issues were with you the last time we saw you. We know what we expect the issues to be. And as we're going, we're strategizing, how much time can I spend on this? How much time can I spend on that? Because all of us know that we would need to be with you for 2 hours to address all of the issues that you have, but we've only got a half an hour. And so if, as I'm telling you, can't wait to see you next time, enjoy your cruise that you have coming up, if you pull out something like a paper or a form or something to complete, it's very, very difficult for me to do that at that time. So if you have a plan of what you want to talk about, if you have paperwork to complete, anything that you have that you brought with you that is of importance, show your hand at the beginning of the visit and we can incorporate that into the entire visit. We'll plan our time based around that. So really, really important for you to do. Bringing an updated medication list. So I know that many of you are on multiple medications, and I know how difficult it is to keep track of them. I take a medication for reflux. I can't remember to take it probably 40, 50% of the days, right? But when you have Parkinson's disease, you don't have the luxury of not being able to stick with your medication regimen. And if you come to see us and you're not exactly sure of what medications you're on, we can't make an intelligent choice to help you, right? We have to know exactly what you're on at any time in order to make a choice that, one, we know isn't going to interact with something else, and two, to know that we're not adding a medicine that is superseded by a different medication. So if you're showing up to your doctor's office and you don't know what's on your medication list, there's no way that you're in the driver's seat. There's no way that you're making the best use of that time. So bring an updated medication list, which is great for you to have regardless, right? Because you never know when you could find yourself having to get admitted to the hospital or someone calls 911. If you have that list on you, it's got your allergies, it's got your medications, it's got your general past medical history. You just hand that to the EMT, and it's a way to keep yourself in the driver's seat. If there's any doubt, bring your bag of medicines. Just bring the whole bag. We can scan through that list of medications very, very quickly. If you're not quite sure what you're supposed to be taking, bring the bag, because what you're prescribed doesn't always match what you're actually taking on a day-to-day basis. So bring your medications or bring the actual bag of medications themselves. Okay, so Yoda says to focus you must, to stay focused, right? So all of us in our normal conversations, we talk to people about things, we bring up different topics, the topics meander around. Sometimes someone will bring one thing up and it'll make you think of something else. This is the way people communicate, and it's normal, and we all do it. But when you're in your doctor's visit, remember, staying in the driver's seat means staying laser focused on what you want out of that visit and on answering the questions that your provider has. So if we ask you something specific, you got to really pay attention in a different way than you would normally pay attention in a conversation, because the sooner I can get through the things that I know that I want to ask you, that I need to know, the sooner we can get to the things that you're concerned about, and the sooner that we can actually have time to maybe address things that we hadn't in the previous visits had time to address. Because as we said, I never finish a visit with a patient knowing that we covered everything that we need to cover. So stay focused like Yoda. Okay, Honest Abe, be honest, right? So I know that for many patients, you don't want to go to the doctor. You're doing the best you can of taking your medications on time. You're doing the best that you can of remembering to take it. You don't want to hear us belly aching at you about why aren't you taking this or why aren't you doing this better. We understand that it's difficult, right? We know how difficult it is. The more honest that you are with us, you might have to hear a little bit more of us encouraging, put it in a nice way of the best way to do things. But that's what's going to help you the best. Because if you're telling me I take my medication 4 times a day as prescribed, I'm going to make a particular change if you don't look very good, if you look like your motor symptoms are not controlled. But maybe you're only taking it twice a day because you can't remember to take it on that. It's that second afternoon dose that's so difficult to remember to take, right? So I could be giving you the wrong medication or developing the wrong approach if you're not being honest. And the same thing with exercise. When we're asking you about exercise, we want to know what you're actually doing, not what you're planning to do. Because I know myself, what I actually do for exercise and what I plan to do are 2 very, very different things. So it's far better to be honest and to let us work through a plan, even if that plan means, look, what the ideal is for exercise or for medication administration, it's just not going to happen. So we've got to come up with another plan. There are things that we should be asking you that we can't always find time to. So sexual side effects is one of those. So if we do ask you about that, again, be honest, we're there for you. And the same thing with anxiety and depression. We're going to talk a little bit more about apathy later, but a lot of times patients see themselves as, I'm not the type of person who would ever be anxious or depressed. But once you have Parkinson's disease, this is a symptom of the disease, the same as tremor, the same as stiffness and slowness that goes along with the disease. So be honest when it comes to depression and anxiety, And especially think about, I can't tell you how many times I see patients where they seem to be describing a situation where anxiety and depression are really significant in their life, but they don't consider it that way. So when you're thinking about depression, anxiety, think about how much does this affect my quality of life on a day-to-day basis? Because half the time that I see patients, I am adjusting their medications for their motor symptoms, but the thing that is affecting their quality of life the most on a day-to-day basis is not their motor symptoms. It's depression or anxiety. Okay, so it's all in the patterns, right? We ask you all these different questions here, questions there. What time are you waking up? What time are you going to bed? What time you take your medicine? What time does it wear off? But a lot of these questions are the same, right? So for many of you, I'm doing the movement disorders exam with you, and you're starting to do the next part of the exam before I even start it, because you're an expert at getting the exam done on you, right? And so it's the same thing. You know some of the questions we're going to ask you. You know we're going to ask you about how long does it take to kick in? How long does it take before it wears off? You know, we're going to ask you about constipation. So these are all things that you can think about either on the drive in or the day before, because the earlier you think about it, the more complete of an answer that you can give us. And you don't have to worry about thinking about it in real time. Take notes. Okay, super important to make sure that you're taking notes. Nobody remembers what the doctor says when they leave the office. It's like you remember the question that you wanted to ask on the drive home, and whatever we say is going to be pretty much gone out of your memory within a day or two. So if you have a partner with you, they can be the note keeper and you can focus on what we're saying, or sometimes you're the note keeper. But taking notes can sometimes, even if it's just small things, can sometimes help you to make sure that the most critical things that are being conveyed to you or that you're conveying are actually remembered and are actually followed through. Because remember, we're taking notes of everything you say. And so when you come back, we know what happened last time. So you should be taking notes too in order to stay in the driver's seat. So this is one that comes up a lot, right? So I will say to a patient, did you ever try amantadine? And I can tell just by looking at them, they're thinking, you've got my entire medical record in front of you. I've tried 20 medicines in the past 3 years. Why are you asking me if I tried amantadine? Just look it up. And the reason we do that, usually when we're asking, we're already in the process of looking up. But the reason that we do that is, again, we've got our fixed 30 minutes of time. And if you could tell me off the top of your head, oh yeah, I was on it, it was 2 years ago, great. We can lock in on that time period and we can figure out, okay, did you not tolerate it? Did we prescribe it and then you read the package insert and you got nervous or didn't ever take it? So it's not that we are sort of putting that onus on you. It's that we're just trying to be as efficient as possible. We know that it's difficult for you to remember those things. We appreciate the effort that you're just trying to put in to remember them. But that's why we do it, because we're trying to make the best use of that time, which is really your time. Nobody remembers everything that we ask you. When you go to see your neurologist, very often it's question after question after question, and you get overwhelmed because you don't remember. And it's okay. We don't expect you to remember everything. We're expecting that a good portion of all the questions that we ask you, you're not going to have an answer for, and that's okay. So don't let it fluster you. Stay on course, stay on track. Know that we're expecting that. And we will work in the best situation. We'll do the best that we can in this situation, because nobody is expected to remember all the details that we would ask you related to your care and related to your history. This is also one that comes up a lot. So nobody's putting on a show, and I'll tell you what I mean by this. Does anybody recognize these gentlemen here? Okay, so we got Frank Sinatra, Dean Martin, Sammy Davis Jr. Those are the easy ones. Who are the guys on the other end? Peter Lawford, right, who was famous because his sister was married to JFK, and then Joey Bishop, who actually was a pretty good comedian. And they used to put on this amazing show as the Rat Pack in Las Vegas. And sometimes if you are the caregiver of a patient with Parkinson's disease, you will see that your spouse will be barely able to walk, or they'll be freezing left and right. And then suddenly they get in the doctor's office and they're walking like a champ. And you're wondering, like, what's going on? This isn't the way you walk at home. This is not real. Like, why are you acting like this? Don't put it on. Show him what it's really like. And it's not that they're putting on a show. It's just the process of the disease. Being at the doctor's office is going to change what a person's symptoms look like. We know this, we expect this. Your tremor is going to be different at the doctor's office than it is at home. Your gait and your walking is going to be different. So if you're a caregiver and you feel like your spouse is putting on a show every time they go to the doctor's office, that's not what it is. We expect it to be different because the dopamine levels change based on the activity that you're engaged in. So does the type of exercise matter? So we could talk for hours about exercise and Parkinson's disease. The only reason I put this in is because I often have patients who tell me, I'm exercising. Okay, that's great. What do? I ride my bike, but they're not doing anything for their upper body. Or, okay, I'm exercising, I'm doing rock steady boxing, which is terrific, right? And then you're testing their fine dexterous movements, and it's terrible because they're not using their hands. They're not exercising and practicing individuating and making their fingers work together. So when you are doing exercise, staying in the driver's seat means working your entire body and making sure that exercise includes strength training, cardiovascular, and stretching. Stretching, super important. Another important one. So judging the value of activities, okay? So when you have Parkinson's disease, you will find that many of the things that you used to love to do are not going to be rewarding anymore. Your body is not, you're going to feel like nothing's worth doing. Should we go visit our family member? Nope, I don't feel like it. Should I get up and exercise? Nope, I don't feel like it now. Should I go out to eat? Nope, not worth doing. Because the part of your brain that's involved in motor function and judging how fast to make a movement, how big to make a movement, is the same part of your brain that's involved in reward. And so nothing is going to feel like it used to be worth doing. And so what you need to do is change that desire for a feeling to an intellectual thought. You're not going to get that feeling of reward. You're not going to get that feeling of, I want to go do this. You have to make it, you have to convert that hooked on a feeling. You guys remember this song? It came out in like 74. Nobody's ever heard of Blue Swede since then, right? It was just that one song. So you have to change that desire for the feeling of reward to an intellectual thought of reward, right? Because you're not going to get that feeling again. It's part of the disease. If you don't make that change, you're not going to be enjoying life the way that you could, and that's not being in the driver's seat. So irritability is one that comes up a lot, right? So irritability can come up in caregivers because it can be very, very difficult caring for someone with Parkinson's disease. And if you have Parkinson's disease and you are not moving the way you used to, and you're dealing with running to the restroom all the time, and you lash out, it's not going to be at me, who you see 3-4 times a year. It's going to be at your spouse, who you see every day. And so irritability is something that really comes up a lot. And it's something that if it's a problem, bring it up, talk to us about it, because there are things that we can do to help you both to work your way through it. And sometimes just bringing it up to the surface is really important. Levodopaphobia. Okay, so there's a lot of patients who, especially when they're early on and they are doing well, are terrified of increasing their medicines. It's almost like, okay, if I increase my medication, that's a failure. That means that something's going wrong. That means that I'm getting worse. And we know that the best care means we focus on best symptom control at any point in time. We don't want to give you more medicine than you need to, but there's no reason to withhold medication like people thought was a good idea to do 20, 30 years ago. So really, really important to not be afraid of dose increases when you need it, or going on carbidopa, levodopa when you need it, because it's going to help you. The goal is to improve your function on a day-to-day basis. And if you are afraid of it and you delay it beyond the time that you need it, you're going to suffer more than you need to. And the same thing with protein. So for whatever reason, of all the things that Parkinson's disease patients need to know, this is the one that gets to everybody. Protein, don't take protein. But there are very few patients, it's the minority of patients, who have any interaction with protein. So what everybody knows and what everybody hears is that protein blocks or interferes with the uptake of carbidopa, levodopa, which is totally true for many patients. But you can't go without protein. You can't stop taking in protein, or your muscles are going to end up, the protein is going to be taken from your muscles and you'll lose muscle mass. So the best way to approach protein is to just eat and take your doses. And if you see a correlation, high protein meal, and then you're not getting as good of an on, that's a good reason to address it. But if you're not noticing that correlation, there's no need to be worried or afraid of protein. Okay, so does anybody remember this song? It's My Party, 63, right? So this was Leslie Gore, no relation to Al Gore, who invented the internet. So this is your party. If I have a plan for what the day is going to be like, for what that visit's going to be like, or even the day, because as we know at our Parkinson Center, you're there for a day or a couple of days sometimes. If I have a plan for that, for what it's going to be, and that's not your plan, you're the driver, you're the one in charge, and you need to let me know, like, I understand that we need to talk about these things, but this is the thing that's most important to me, and this is what I want to prioritize, and that's what we will do. And we will always, you know, we'll work with what's safe, but at the same time, you have to be in charge of making sure that you're getting your desires and your needs met. So teamwork makes the dream work. So at UF, we are very lucky. We have integrated physical therapy, occupational therapy, speech therapy, genetic counselors, social workers, psychiatrists, neuropsychologists. It's terrific. Outside of that type of setting, it's very, very difficult to get anyone to talk to each other, right? So Dr. Oken has said for many years now, the patient is the sun and we orbit around them. And when you come to UF, that's easy to do. I can walk down the hallway and talk to your physical therapist, or walk in the other direction and talk to Dr. Foote. But outside of that setting, it's very difficult for all those people to communicate. So putting together a care team is difficult. It's going to be difficult, expected to be difficult, but it's important because the best care for Parkinson's disease is interdisciplinary care. A quick note about too many cooks in the kitchen. So many of you may have local neurologists who you see 2 times a year, 4 times a year, and you just check in with us once a year. And it works. And it works because there has to be the quarterback. There can only be one quarterback, right? So you can't have one person pulling in one direction, coming up with one plan, and then we're pulling in another direction, coming up with another plan. Now, you can have 2 neurologists, a local neurologist and us. That's the hub and spoke model that Dr. Oken's been describing for decades, and it works. But there has to be one person making the changes. So either we can be the person making the recommendations and your local neurologist can make the changes, or we actually make the changes when we see you. But there has to be one quarterback. Otherwise, you're not going to be getting the best care because you're just going to be getting pulled in different directions. Any VA patients here in the crowd? I don't see any today, but we may have some VA patients connected remotely. If you are a VA patient and you're seeing an academic center or a private practice on fee basis, remember, don't give them your insurance cards, because if you do, you're going to end up getting double billed, right? Because if you're getting fee basis care, they're going to, when you walk in the door, they're going to do the same thing that they do with every patient. Can I see your insurance cards? But you don't want to give them your insurance cards. You want to say, I am here as a VA patient on a fee basis, because otherwise you could run into the problem of getting the double bill. Obviously, if you're a VA patient, but you're using your Medicare, then you give your Medicare card, but just something to be aware of. If you are in the VA system, it's a lot more difficult to get prescriptions. They have to go to your primary care doctor, who then has to prescribe them. They have to be on formulary at the VA. So if you get community care and they recommend a medication, there's no guarantee that that medication is going to be actually available for you, or that you'll meet the criteria for it in the VA system. And the same thing with therapy. At the Movement Disorder Center at UF, we have an amazing physical therapy group. I would love to send every veteran there. The VA is only going to send you there if they can't provide a service that the VA can provide locally, right? Because it's a cost issue. And the same thing with neuroimaging. It's difficult to do. So if you have the capability of getting imaging done at your movement disorders or at your neurologist's office, that's always the best, because then we actually get to look at the pictures. It makes it as easy as possible. Okay, so don't improvise between visits. So who is this on the left? Miles Davis, that's easy. Who is it on the right? Dizzy Gillespie, the cheeks, give it away. Who is it in the middle? No, not me. That's Bill Evans. So between visits, we give you a plan. You don't want to be improvising with regard to your medication regimen, okay? You want to follow the plan that we provide for you, because if you come back and you have done something that's different from what we recommended, and it's different every day, we can't make an intelligent decision about what we recommend for you to do in the future. So if you have a concern and you want to make a change, just give us a call and run it by us. Now, I know that sometimes it can be difficult to get in touch with any doctor outside of your regular hours, but you have the portal, and at least at our center, we have our fellows who help with messages, and we will get back to you. Don't improvise like these gentlemen here, or it's not going to be being in the driver's seat. It's not going to give you the best care. how frequently you need to be seen. So this is different for every person. It's different in every practice. Sometimes you might see us once a year and you'll see your local neurologist more frequently. Sometimes it'll be as frequently as every 3 months. Sometimes you'll be doing great and you won't need to be seen very, very frequently. So it's going to be dependent on a lot of different factors, and it's really customized for each individual person. If I say to you, wow, you look like you're doing great, I'll see you in 9 months, and you tell me, I don't feel comfortable with 9 months, you have to tell us and let us know, and we'll talk it out. We'll figure out with a plan. Why do you not feel comfortable? Maybe we need to switch to 6 months, or maybe I just need to reassure you that we're good for 9 months. So different for every patient. If you have concerns too soon, not soon enough, just let us know. So I talked to you today about some ways that you can make sure that with regard to your Parkinson's care, you are staying in the driver's seat, because Parkinson's disease is now with you on this journey. We can't kick it out of the car, but the only thing that we can do is make sure it's not driving. So thank you all very much. This is just a summary of the takeaway points, and thanks for your attention.
Okay, that was wonderful. Next, we are so delighted to have one of our fellows, Dr. Enrique Martinez, who's going to be talking to us about biomarkers. This is something that's received a lot of attention, the world of biomarkers, and that means you're going to learn what that means in just a minute. Something that can help support the diagnosis and identify if a person has Parkinson's. After that talk, we'll have a break where people can get some coffee or drinks. Dr. Dorsey plans to come back and do book signing, and then we'll split into the 2 different tracks. Martinez.
You're about the same height. Oh,
Oh, I'm sorry. Thank you.
I feel taller now already. Hello, everyone. My name is Enrique Martinez. I am a fellow at the University of Florida. I'm following the very tough act that is Dr. Hess's amazing stand-up routine. But we'll talk about biomarkers. This is probably a question that I hear many times and very frequently. So you probably had questions about whether there's some tests for Parkinson's that you can do and whether you need it. So we'll talk about that today, how it works. Before we start, just acknowledging that Amil Pharmaceuticals pays for part of my training fellowship, which is great. Nothing of what we're talking about today has anything to do with them. So we'll start talking about how do we diagnose Parkinson's. So when we start fellowship, Dr. Hess makes us swear we will never tell anyone. This is protected information. Nonetheless, I'm going to tell you today against his instructions. We'll start with some history. As you may have already noted, all neurologists are a bunch of nerds. So going back into 1817, when the first human who described Parkinson's disease, James Parkinson, described it by only seeing 6 patients with Parkinson's, and he made the description. And it's even more amazing because 3 of them were his patients and 3 of them were people that he just saw walking on the street. So even since then, you can tell that Parkinson's is all about observation. It's all about seeing how people look. This is a drawing that was made by a guy in the 1870s, Gowers, that shows what we classically call now Parkinson's. Someone who stooped over, hands flexed in this kind of position. You can see one of the hands is shaking. It's asymmetric. One of them is a little bit more clenched than the other one. The little steps that they take when walking, the decreased facial expression, those are the things that you can just see and know that it's Parkinson's. So it's very much relies on observation. And of course, since 1817, we figured out some of the things that can be seen in Parkinson's. We now know it's a more of a complex thing. When we see on younger women, they start having foot curling or dystonia. People who take medication now, which was not a thing back then, can get dyskinesia. That is also something that is seen very commonly in Parkinson's, but the same things, stooping, the tremor. So what is the best way to figure out if someone has Parkinson's disease? And honestly, the best way is to examine someone's brain. There is 2 changes that Dr. Dorsey mentioned. One of them is the loss of the cells that produce dopamine in the brain, and a particular part called the substantia nigra. So here on the right of that image, you see what a normal midbrain will look like, which is dopamine producing cells have kind of that black pigment, so it looks really, really dark. And in someone who has Parkinson's, it looks paler. So those strips right there that look a little bit more brownish or lighter on the left in the Parkinson's brain is because they have less dopamine producing cells. So it's one thing. The other thing is in that part, if we look at them through a microscope, we'll see the small clumps of abnormal proteins accumulated of a normal protein called alpha-synuclein that you might have heard about. So two things that we can see for sure. One, less dopamine producing cells. Two, accumulations of alpha-synuclein. So that is the best. But for that, we need to examine someone's brain. And all of you here are still using your brain, so we can have that. Well, maybe a couple of people who I know they may not be. But while we're still using your brain, what is the best way to figure it out if you have Parkinson's? And the best way is being seen over time by a neurologist who sees a lot of patients with Parkinson's. Still, for sure, that is absolutely the best way to tell if someone has Parkinson's. Over time, being seen by an expert. But humans, unfortunately, are not perfect. So we cannot tell 100% of the time. And you may have run into the situation where your neurologist is not completely sure that what you have is actually Parkinson's. And that point is then when we use technology. Technology is awesome, right? Technology has solved a lot of our problems. So why not the Parkinson's stuff too? We have very high super resolution brain images. We can make brains tissue transparent. This is something really cool. That's a mouse brain on which we can basically dissolve the fat and see cell by cell transparently. That's super awesome. That's a mouse brain. We have AI, right? AI does everything. We have the computers to run this very advanced stuff. So we should be able to do something with it for Parkinson's, correct? Yes. So we'll start to talk about some tests that might identify these two things that we talked about to figure out if someone has Parkinson's. So what should we look for? Less dopamine cells in the brain. Less dopamine cells in the brain and accumulation of abnormal proteins, alpha-synuclein. So those two things, less dopamine, more alpha-synuclein. Can we just see the cells that are missing in a brain scan? That's the easiest thing, right? You don't even need to get poked. You don't need to do anything. Just get a brain scan and we figure it out. And we sort of can. There's this test called the DAT scan or DAT SPECT that you may have heard about before, on which we have you do a scan to see what your brain looks like. Then we give you a dye. The dye binds to the dopamine producing cells in your brain. And if it's really shiny or sparkles a lot, that means you have a lot of dopamine producing cells. If you have less of those, that means that you have less. Therefore, you may have Parkinson's. The image on the left, that's what a normal brain should look like. You see those like really bright yellow clumps. That's what it should look like. That kind of looks like a comma backwards or parenthesis. The image on the right, it's someone with Parkinson's where you see less of that super shiny yellow signal. So that just means there's less dopamine producing cells. Therefore, this person has Parkinson's. So it's a pretty good test. It's been around since the 90s. The good part about it is that it's accurate in about 80 to 90% of patients, which is great. That's a lot. And we only do it on patients who really need it, and we don't really know if what they have is Parkinson's. It also gives us objective biological information when the clinical examination is not clear, which is exactly what we want. We want objective data to figure it out, have a sort of a count of how many dopamine producing cells there are. The bad part is that it does involve radiation. It's a brain scan. And the other one is that it's not accurate in 10 to 20% of cases, which means that not everyone who has a positive or a negative test, we have completely ruled out Parkinson's. It's slightly more complicated than that. It's not like a single test that you can get and say, yes, Parkinson's, no Parkinson's. Another thing is that it looks a lot like a lot of other neurological conditions you might have heard of that are related to Parkinson's: progressive supranuclear palsy, multiple system atrophy, corticobasal syndrome, and dementia with Lewy bodies. All diseases that also have stiffness, tremor, rigidity, and can look exactly like Parkinson's. So that will not help us with that. So it's a great test, but we can do more. What if we could just see alpha-synuclein in a brain scan? What if we just get counted and see it? Unfortunately, we can't do that. We don't have a way to scan it or count it yet. Oh, okay. We have something that kind of works like that for Alzheimer's. So we have a model for that. For Alzheimer's, the abnormal protein that's accumulated is called amyloid. and we have a substance that can bind to amyloid, and we can do a brain scan and see it there, which is really cool. So for Alzheimer's, this already exists. So there's something that we're trying to do similar to Parkinson's. On Parkinson's, we're trying to develop this sort of like tracer or thing that will bind to alpha-synuclein and make it shiny for us to be able to see it in a scanner. So a couple of tracers are being developed. They're still in lab studies where they may come up to actual studying it in patients in the future, but not yet. So I'm gonna stamp this as actively working on it. And can we just see anything abnormal, right? You would think that a normal brain looks different than the Parkinson's brain. And there's probably some small but significant structural changes in the brain that you should be able to tell looking at a brain scan, right? It's hard to think that brains can move completely normal in Parkinson's, as it often is. And the reality is that there's very, very small microscopic changes that are hard for us as humans to look at. It will require a lot of work and counting and processing to figure it out. So it's just impossible for us to see it as a single human. Now, this is one of the things that we can let the machines do. How this will work is you get a brain scan, then we scan it through a machine learning AI algorithm that counts and looks at very specific places and tries to figure out what is the likelihood of you having Parkinson's. And this is already real. This is really awesome. This is work being done here at the University of Florida by Dr. Valancourt, Dr. Ramirez, Dr. McFarland, Dr. Okun at the House of the Gator, where we do this sort of quantifications of how much water moves in this specific part of the brain. And that microstructural changes can help you predict if you have Parkinson's or not. So you just run the images through it and it tells you how likely it is that what you're seeing is in fact Parkinson's. So it's really cool. This is soon after coming to actual patient care. So this is getting really, really close. So this is great. So again, something working on it is gonna get there soon. Now, can we just check someone's blood for alpha-synuclein, right? Like if we know that's abnormally high, we should be able to get a blood draw and measure it. Unfortunately, it doesn't work that way because most of the alpha-synuclein is in the red blood cells. So if there's a slight increase, we can't count it because sort of like a drop in the bucket. As an analogy for this, let's say that Dr. Hess is walking down the street and sees a $100 bill. He doesn't stop to pick it up because based on his net worth, that's nothing compared to the rest. So he doesn't even stop. But for Alzheimer's, we already have something like this. So it is possible. There is an abnormal protein in Alzheimer's called p-tau, and we can measure it in blood. And this has helped tremendously in the last couple of years to diagnose who has Alzheimer's disease. So it's a reality. We're looking at more markers in blood and spinal fluid to figure out whether this is something that you can find in people with Parkinson's. So there's a list of markers of things that we can check and figure it out whether someone has a higher risk of having Parkinson's. So in blood is getting closer to, again, working on it, getting close. Now, can we just grab someone's brain, take a piece of it and see if they have Parkinson's? No, I will not go that far. It's probably too much. We're definitely not working on that. That sounds illegal. But we can get creative. And we know that alpha-synuclein is not only in the brain. It's not only the substantia nigra. It's everywhere in the brain and in a lot of places in the body. As you all know, Parkinson's affects all the nervous system, and the nervous system goes anywhere. So we can see alpha-synuclein accumulations in all of those organs. The easiest one to explore, skin. So it's very easy. You just grab a piece of skin and see if there's alpha-synuclein in it. And that's exactly how it works. You may have heard we have this alpha-synuclein skin test. You can do that device that kind of looks like a pen. It's very, very small. You grab a skin of about 1 centimeter deep. For the imperialists, that's about ½ an inch. And you grab it from 3 places: back of the neck, back of the thigh, back of the leg. And you can figure it out. And if you see synuclein, which is those real small red dots, and the green spaghettis are nerve cells. If you see alpha-synuclein inside of the spaghettis, that means they have alpha-synuclein, therefore this is probably Parkinson's. That's really cool. That's another test that's already out on the market, already being done, already being really helpful. Accuracy is pretty good. 80 to 95% of the times it's accurate, which is great. So it's slightly better than the DAT-SPEC. So it's really good, depending on who you ask. It's really easy to do. We do it in the clinic. The bad thing is that some part of it can, some people who have a positive test may not really have Parkinson's. Alpha-synuclein in the skin does not necessarily mean Parkinson's. So again, like with the DAT scan, the most important thing is the right patient needs to get the test in order for it to make sense. This is not something that I would recommend everyone to do. So if you're walking down the street and someone says they're doing free skin biopsies for anyone around, you have no symptoms, this is not for you. This is something that should be done specifically for people on whom we think they may have Parkinson's disease. Really, really important for the right person to get the right test. Again, some conditions can have a positive test, like multiple system atrophy, dementia with Lewy bodies, and pure autonomic failure. All of those also have alpha-synuclein. All of those will have a positive test. Again, the importance is to figure it out who needs a test. So where are we at? We have two really nice, minimally bothersome tests that can help us figure out if someone may or may not have Parkinson's. We have a bunch of new tests coming, more accurate, less invasive. It's even getting better. Do you need it? Most likely not. Most people with Parkinson's, we do it the 1817 way, and it works pretty well. And that's the best way to tell, by far. But sometimes it's needed. And if it's going to be a test that's going to help you and your neurologist to figure it out whether you may actually have Parkinson's and whether your treatment may change, that's where the tests come handy. But still, the best diagnosis tool is a good neurologist and time. At least there's nothing better yet. Thank you for coming.
Okay, that was fantastic. Now we're going to have a break for 15 minutes. There's water and coffee on the table. If you would like a hand for someone to bring you the water or coffee, just raise your hand and our volunteers will come and get what you need for you. Right after the break, we're going to have a session in this room about medications and pump therapies, some new therapies we have for Parkinson's. In the room down the hall, we're going to have a talk on the PD generation study. So we heard about environmental risk factors, and we're going to talk about genetic risk factors. If you miss one, you can get the other one online later. So now we have a 15-minute break. Dr. Dorsey and Dr. Oken are here to autograph their book, and they have free copies available, encouraging people to pre-order their next book. They have a link for that. And the bathrooms, again, are out the front and out the side over here. Just raise your hand if you need a hand to get a drink.
If everybody can start going to their seats, we'll have our next presenter. Remember, if you want to do the Parkinson's 101, that is going to be in the room to your right. And if you want to stay here, it's for experienced patients with Parkinson's. We're going to get started in about 2 minutes, so please take your seats. If I can get Dr. Curry to come up here. I'd like to present Dr. Amanda Curry, one of our fellows, who's going to be speaking on the updates of medication and pump therapies in Parkinson's disease. So give her a round of applause.
Great. Good morning, everyone. I'm just going to get my timer set up so I can keep an eye on time here. Great. Okay. Well, good morning. First of all, I'd like to start by just giving a round of applause for our fantastic speakers this morning. Those have been some really inspiring talks. So thank you so much, everyone. All right. Thank you all for choosing this room for the people, experienced people with Parkinson's disease. I call it the big kids table. So I'm glad you're here with me this morning. I'm looking forward to speaking to you about some new updates on new medications and pump therapies for people with Parkinson's disease. I'm Amanda Curry. I'm one of the second-year movement disorder fellows here at the University of Florida, and I feel very fortunate to be able to learn here from these fantastic teachers and from all of you patients, caregivers, spouses. Feel very fortunate, so thank you. All right, so without further ado, let's get started here. First of all, I don't have any conflicts of interest to disclose, but I do want to thank the Davis-Rembert Family Foundation for funding my fellowship. Here's a little outline of things that we'll be covering this morning. First, I'd like to start with just talking about our current drug therapies and what the current landscape looks like. Then we'll move on to a newly approved drug that hit the market in the last year. Next, we'll talk about the pump therapies that are available right now, and then one that's coming soon. We'll talk about other new drug therapies that are kind of on the horizon, things we can expect in the next few years. And finally, we'll touch on a couple of topics that have been a lot in the news in the last year or so to kind of go a little bit more in depth about those. So kind of setting the stage for some of the things that we'll be talking about. When we think about treatment of Parkinson's, it's all about the dopamine. So the primary problem with Parkinson, as we've heard from several of our speakers this morning, is that the brain doesn't make enough dopamine because of death of the cells in the brain that make the dopamine in the substantia nigra. So as you can see, there's dopamine that's involved in several different systems within the brain, and some of them will make sense when you think about some of the symptoms that you or your loved ones might have with Parkinson's. So in the red, we see the movement-related symptoms, where dopamine is involved with voluntary movement production. And then you also see other symptoms that are involved, things like thinking, memory, learning, motivation, different emotions, and reward processing. All of those are affected by dopamine. And so you can see how adding back dopamine can help restore some of these symptoms back to more normal levels. So just kind of looking briefly at a history of Parkinson's treatments and history in the last couple of 100 years, you can see that Parkinson's disease was systematically described back in 1817, and then it wasn't until the 1950s or so that we started to get some treatments in the form of surgical therapies. And then we got our first FDA-approved, or one of the most effective FDA-approved drug therapies for Parkinson's disease in 1970 with the approval of levodopa. And many of you will recognize that because it's the active ingredient in carbidopa-levodopa, one of the medications that most people with Parkinson's will take at some point in their journey with Parkinson's. Then in the 90s, deep brain stimulation came on the scene and was approved by the FDA. We had approval of pump therapy in the form of Duopa in 2015, more recent approval of focused ultrasound therapy, and here we are in 2025. Dr. Burke will be covering some of the things there at the bottom of the slide, but we'll focus more on the top part in my talk today. So just kind of reviewing some of the things that a person with Parkinson might describe and might experience with regard to their medications throughout the course of Parkinson's disease. To orient you to these graphs that you'll be seeing in the next couple of slides, on the bottom are the time during the day. And then on the vertical axis, you see the dopamine level in the bloodstream. The shaded blue area is kind of our therapeutic window, the place where we want those dopamine levels to really stay for the majority of the day. I kind of call it like the Goldilocks area, sort of. You don't want it to be too high, you don't want it to be too low, you want it to be just right. And what happens if you get outside of that, on the top side, you'll get the high dopamine side effects that you all might have experienced. Things like dyskinesias, those extra involuntary movements. Could be things like hallucinations or orthostatic hypotension. So those are things that we would like to avoid if we can. And then on the other end of the spectrum, down at the bottom of the window, you'll see some red areas, and those are kind of the off symptoms. So almost as if you're not taking those medicines. You're seeing your Parkinson's symptoms returning, the stiffness, the slowness, the tremors, and the feeling like you just need more of that dopamine. So here in the early stages, you get pretty good continuous benefit from your carbidopa-levodopa. You don't get many of those fluctuations or the highs and the lows, and you're going along pretty well with just taking your medicines a few times per day. Moving on to kind of the middle stages, after people have been living with Parkinson for a little bit longer, you can see we're starting to get some of those fluctuations, or we're getting out of that Goldilocks period. We're getting some of those dyskinesias up at the top. We're getting some of those off periods down at the bottom. And then as Parkinson advances, you'll see people often have to take their medications more frequently, and they spend more of their day in either the high or the low area outside of that ideal therapeutic window. One more thing I'll highlight on these slides is the term that the trials like to use that I'll be referring to as we go along for that blue shaded area is good on time. Okay, so if we think about how we can best manage the symptoms for people with Parkinson's disease and maybe manage some of these fluctuations, we've got several different approaches that we can think of, and most of them make a lot of sense. So number one is you can just increase the dose of levodopa if you're just not getting up into that shaded blue area. You can also increase the frequency, so take it more times during the day. You can also try different controlled release formulations. Some of you might have tried this in the form of Cinemet controlled release or Cinemet CR. We also have Rytary that's an option that uses this mechanism too. It lasts a little bit longer. Another option that we have is to prevent the breakdown of levodopa before it gets to the action where it can do its benefit. A couple different medication classes use this mechanism. One of them are the MAO inhibitors, so things like selegiline, rasagiline, or things like Azilect that you might have been familiar with. And then the other one is COMT inhibitors in this enzyme preventing breakdown category. And those are things like entacapone or tocopone or opicapone. Next, we have an approach to treating Parkinson's symptoms that involves stimulating the dopamine receptors without increasing dopamine itself. And so that that class of medications is called dopamine agonists. And so those are medications that you might have heard of or tried, things like ropinirole, pramipexole, Nupro, or rotigotine, and one that we'll talk about a little bit later on called apomorphine. Finally, you can think about continuous drug delivery devices and strategies to help kind of smooth out that delivery of the doses throughout the day. And things that use that mechanism are things like pump therapies or transdermal patches that deliver the drug more evenly during the day. So you might ask, we've known about Parkinson's since the 1800s. Why don't we have more treatments that are available for people to try? Well, a lot of that comes down to it just takes a lot of time for drugs to move through this approval process. On average, it takes somewhere around 10 years or so to go through from the preclinical or the animal and cell-based models into the when it hits the market, when it's available for us to use in routine clinical care. And then kind of the earlier phases focus on making sure that the drug is safe for people to take, and then establishing, does it really treat the symptoms? Does it do what we want it to do? Once they have that data for enough people, usually in the range of hundreds to even thousands of people, they can accumulate that data, present it to the FDA, and the FDA can say, yes, we approve it for use in routine clinical care, or no, we need some more information, come back and try again later. Throughout the presentation, at least for the new therapies, I'll be focusing on medications that are in the phase 3 clinical trial range that are most likely to come to the market soonest, just to kind of focus our discussion a little bit. And those trials will be denoted by this black circle 3. So that'll be the key that I'll use throughout the presentation. Okay, so you might think, how do we measure Parkinson's symptoms in these trials? What are some endpoints that we use? And they fall, at least in this trials that we'll be talking about, into 2 big categories. One are rating scales. So those rating scales can be things that your doctor observes based on an office visit. So a lot of you are familiar with the examinations that doctors do every time, or the movement specialists do every time you come into the office, this sort of thing, this, checking your tone, all of that. So that's part of a rating scale that doctors observe. And then there's also patient-reported rating scales, things where you rate how your symptoms are doing. So how are you doing with bathing? How are you doing with brushing your teeth? How are you doing with speaking, with choking? That sort of thing. And then the other category that we think about are how well and how long do you think your medicines are working? So how long do we think that you're staying in that Goldilocks period, the blue period that we talked about before? And there's two kind of measures of that are used in the trials. One is how much good on time are you having? And so that's the area in that blue bar. And then the other metric that's often used is how much off time are you using, or how much off time are you having? How much of the red below the therapeutic window are you spending? Okay, so now that we've kind of set the stage, I'll turn and talk about the newly approved drug that's hit the market in the last year. That drug is called Crexont. It is a new formulation of carbidopa-levodopa. And what that is, it's a capsule that contains beads. One of them is a slow release, and then one of them is immediate release. So it is designed to kind of give you more continuous effect of the medication throughout the course of the day, without having as much of those highs and lows and without having to take it as frequently. It was approved just last August of 2024. And we'll look at some of the data that led to its approval so that you can kind of learn about what we're analyzing when we think about these trials. So basically, they found that the amount of good on time per day in that Goldilocks period was 0.7 hours compared to optimal oral therapy with Sinemet. And conversely, the amount of off time per day improved by 0.6 hours compared to Sinemet. And then one important thing to note here is that the people who got the active drug, the Crexont drug, only had to take their medications 3 times per day compared to the people in the carbidopa-levodopa or Sinemet group who took them 5 times a day. So even that in and of itself is really helpful for a lot of people because that schedule is a lot easier to keep up with compared to having to take the meds so frequently. With all of these different treatments, it's important to think about what side effects are we having? What would we potentially be giving up with a therapy like this? Or what would you have to deal with that's new? And those side effects in the Crexont trial were pretty infrequent, all in less than 5% of the people, and included nausea, anxiety, and dyskinesias, really symptoms that can happen with most of the levodopa-based therapies that we see in use today. So you might ask, this is great that we have this new medication on the market. It's exciting. It's exciting to have to take it fewer times per day. Who might be a candidate for this therapy? And what's been our experience with getting this therapy to patients? Since it's new, it's more expensive, and insurance companies are not as eager to cover it. So in my experience, it's usually a good option for people who have tried things like the immediate release carbidopa-levodopa and maybe a couple of other medications and just aren't having the responses that we would like to see. And so this is kind of something that we try later on in that progression of things that we try for Parkinson's disease. Okay, next we'll turn to some of the pump therapies that we have for people with Parkinson. And again, I'll kind of touch on when I would expect to use these sorts of therapies for people with Parkinson. Usually it's in people who have had, again, good trials of oral medications and they're just not working for people. They're having to take their medicines too frequently. They're having too many side effects, too much dyskinesias, too much off time, or they just can't tolerate the levodopa for whatever reason. Could be that they have a lot of nausea when they take their oral carbidopa-levodopa. Or that it's just not working. They might have some gastroparesis or some GI concerns that make medication delivery through the mouth just not a good option. So those are the kinds of people that I'm thinking about could be candidates for these sorts of therapies. The first pump-based therapy we'll talk about is Duopa. As I mentioned, this one came on the market back in 2015. So we have a pretty good track record of using this, and we have a lot of people in our clinic who we still treat with Duopa pumps. And the way that this drug works, it's just a continuous infusion of carbidopa-levodopa into the small intestine. So the idea is, again, you give it throughout the day and avoid those highs and lows and just kind of stay steady throughout the day. One thing to think about practically for this therapy is that it does require a surgery to place the tube that is used to deliver the medication. But that's a one-time surgery, and then the tube kind of stays there throughout and delivers the medication. Here's a little schematic of what it kind of looks like. So you see the tube that goes down into the small intestine and then is connected to a device outside the body. That bottom part is the cartridge that stores the medication. And then the top part is the way that you interact with the pump and that we program it and that you can give an extra dose if you need to. Looking at the phase 3 trials that have studied this before, it led to pretty good improvement in off time per day by 1.9 hours compared to the regular oral Sinemet. And then similarly, the good on time per day really improved by the same amount, 1.9 hours. So if you think about that, having 1.9 hours of better on time and of reduced off time, who in here would take that and think that that would be a good improvement, a meaningful improvement? I think it definitely would for a lot of people. Here's another just kind of picture to show you kind of the size of these pumps in comparison to holding it in someone's hand. So they're kind of larger, but the company makes some ways that you can carry it around your neck or in pouches, that sort of thing. But it's another consideration that you would need to figure out how to live your life with this pump. Okay, now we'll talk about our first new pump therapy that was approved in the last year. This one is Vyalev. So it was approved just last October in 2024. The medication that this pump delivers is a form of carbidopa-levodopa, but like a prodrug that's then converted to carbidopa-levodopa, and that's what acts to reduce Parkinson's symptoms. It comes as a subcutaneous infusion pump. So if you know someone who has an insulin pump, it's a very similar idea. So it's a small pump, and you just put the needle like underneath the skin. It doesn't require surgical placement of a tube. And then it delivers the medication constantly throughout the day. Looking at the phase 3 trial data that led to its approval by the FDA, we saw an improvement in off time by 1.8 hours compared to Sinemet, and an improvement in good on time per day, again, by 1.8 hours compared to Sinemet. Like I mentioned before, it's really important to think about what we might be giving up or what side effects you might have starting with these types of therapies. And the most common in these trials were definitely related to the site where the needle was inserted on the stomach. So a lot of people, like over a quarter, saw redness and some pain at that site where the needle was inserted on the stomach. And then another significant portion of people saw skin infections, some swelling where that needle was inserted, and then another common side effect was dyskinesia, so those extra involuntary movements. For this one, it's you change the needle like every 1 to 3 days, and they recommend that you kind of rotate the site where the needle is inserted to kind of hopefully help prevent some of those skin-based side effects. Okay, a few practical considerations that I think are important to mention if you're interested in this therapy or thinking about it for yourself or a loved one. Right now, since it's so new on the market, we're sort of figuring out how it's working with insurance. And based on the information that's on the company's website and that the company has told us, we're only using it in people who are 63 years of age and younger and who are not on Medicare insurances. The website says that they hope that that is going to change in the next, within the calendar year, hopefully later in 2025. But we'll just kind of have to see what happens with that. Other things that might make you a good candidate for this therapy, people have to have a good response to oral carbidopa-levodopa. That is, their symptoms respond to carbidopa-levodopa. And then the second thing that is a requirement before starting this therapy is that people have to have at least 2.5 hours of off time when they feel like their medicines aren't working per day. Here's another schematic, just kind of showing the size of the pump in comparison to a person's body. And then it shows kind of that site where the needle is inserted. There's kind of a patch, like a sticky patch that holds the needle in place, and then this small tube that runs up and connects to the pump. And you might think, how would I go about my life living with this pump? How would I carry it around? What would I do with it? That sort of thing. So as I mentioned, the company came by and gave us a little bit of information, a little info session a few weeks ago. And they did bring a little demonstration of how people might live with it. And so I'll show you some photos of our experience with that. So here is Dr. Martinez Nunez. He was trying on this carrying device. It comes in many sizes, but they only brought the small size that day. But because he is such an empathetic clinician, he decided that he needed to try it on and see what our patients might be experiencing. So this is me helping him apply the device. He liked it a lot. It was Dr. Martinez Nunez approved. Until it wasn't, it got a little bit tight and he got tired of it. So that's just kind of joking. I think that the pump goes in kind of those squares that are on the side of the vest, but they make other ways that you can carry the pump around in a way that's as least invasive as possible. Some people even put it in their pockets if their pockets are big enough. And then you can also see kind of the size of the pump there on the table and some of the things that are required to place the needle and change and prime the pump and that sort of thing. So this is a good time to also bring up the idea that coming along with a lot of these pumps, there's some ways of maintaining the pump and using the pump that require some dexterity. And that can be difficult for some people with Parkinson who might have stiff and slow movements, or might have trouble with those fine dexterous movements. So in thinking about if you might be a candidate for these therapies, having a caregiver who could help with those sorts of things can be a really helpful asset if it's available to you. All right, next we'll move on to our next pump-based therapy that was again approved just in the last year. This one is called Onapgo. That's the brand name. The drug that it delivers is called apomorphine. It's one of those dopamine agonists that I mentioned in the first slides. So basically, it stimulates those dopamine receptors and acts as if there's more dopamine in the system. Although the word morphine is in the title, it's completely unrelated to morphine or any opioids. That's just the name that it has. So this one was approved just last March in February, and we're still kind of working through how this is going to go with insurance and with coverage and how exactly we're going to implement it in the clinic. So more to come on that. However, it does have a pretty good track record of use over in Europe, and it's actually been used over there since like the 1990s. So that part's reassuring that we've had some good responses in routine clinical care in a large population of people. Looking at some of the data from the phase 3 clinical trials again, they found that the amount of off time per day improved by about 1.9 hours, and the good on time per day improved by about 2 hours per day, again, compared to the best oral medications that the patients were on. All right, here's another kind of schematic of the device, because I think it's helpful to be able to see what you would be working with if you're interested in this device. So it's, again, pretty small. It has the medicine cartridge attached to it and that small kind of patch thing that holds the needle in place that goes onto the stomach. And again, we'll review the side effects because I think that's important for you to have a good understanding of. Again, by far and away, the most common side effects are skin-related side effects. So things like nodules at the site, even more common than the Vyalev pump in up to 44% of people in this phase 3 clinical trial. And then there was also a lot of redness at the infusion site. Others are more related to the drug itself. So those side effects were things like nausea, increased sleepiness, more dyskinesias, and then some headaches and insomnia. And then importantly, the company just came out, or the results of a follow-up study were recently published where people continued on this therapy for 1 year. And about 70% of the people decided that they wanted to stay on the therapy. And they looked at how well people did over the course of that 1 year, and they still had that good improvement in the on time and the off time. So that suggests that the benefit is sustained at least for a year after starting the therapy. And then the last pump that we'll talk about is one that's approved or that's being kind of considered by the FDA, but hasn't been approved yet. It's called the ND0612 pump. It also is a subcutaneous infusion that delivers carbidopa-levodopa, pretty similar to the Vyalev pump that we mentioned before. It actually came to the FDA before the Vyalev pump, but then the FDA wanted some additional information, so they're working on supplying that. But looking at the phase 3 clinical trial data, again, improvements in good on time by about 1.7 hours and less off time by about 1.4 hours compared to oral Sinemet. And again, going over those side effects, they included pretty common, over half of people, some sort of infusion site reactions. Most of them were mild and not too troublesome, but they did occur pretty commonly, over 50% of people. So here's a slide that might be helpful for you if you're considering the different pumps. What's the differences between them? What's the active drug that's being delivered? Is it approved by the FDA? And then how much improvement are we looking at? So they're all pretty similar as far as improvement, somewhere between the 1.4 to 2 hours of improvement in off time, and similarly like 1.5 to 2 hours of improvement of good on time per day. Okay, for this next part of the talk, we'll talk about a few therapies that are on the horizon and ongoing clinical trials. The first one we'll talk about is called Ambroxol. It was originally used as a cough medicine, but it's being repurposed for treatment of Parkinson's disease with the thought that it might reduce levels of toxic proteins that Dr. Martinez-Nunez talked about, the alpha-synuclein, and potentially lead to disease modification, which would be a great advancement. In a recent kind of earlier phase trial, they saw improvement in movement scores, so those clinician-rated scores, by 6.8 points compared to baseline. And you might say, that doesn't mean very much to me. Is there a difference between 2 and 200? I don't know. So some researchers have kind of defined what matters to patients, what's a clinically meaningful improvement in those scores. And what they found was that an increase of about 3.25 points is what matters to people with Parkinson's disease. That sort of an increase is when people say, yeah, you know what, I do feel a little bit better than I did before. So as we talk about movement scores in the next few slides, be looking for that about 3.25 as something that matters to people with Parkinson. So we don't have any phase 3 trial data available yet because those trials are still ongoing. So there's one that's recruiting in the Netherlands right now, and then another in the UK that's planned but not enrolling yet. So more to come on this one. The next one we'll talk about is called CVN 424. It's got a new mechanism of action that we're not very familiar with. It comes as a liquid that's taken once per day. And it's kind of an add-on to your other Parkinson medicines. It wouldn't be the only Parkinson medicine that you take. One of the earlier phase trials tested 141 people who took the drug for 28 days. And they saw improvements of about 1.1 hours of less off time compared to placebo. So pretty good improvement there. However, no improvement in good on times or in those movement scores. They're working on a phase 3 trial right now, and they're expecting the results of that in 2026. So more to come on this one. The next one we'll talk about is butanetep. It's got another new mechanism that prevents those formulations of formations of the toxic proteins alpha-synuclein. It's an oral pill that's taken once per day. Some of the earlier trials showed improvement in movement scores by 4 points, so kind of right on the cusp of what matters to people. However, an interesting and I think important finding was that it improved scores of cognition on one of the tests. So that might be an important thing to look out for because that would be a huge benefit in people with Parkinson if it holds up in future trials. They're working on publishing the data from a phase 3 trial. It's not available yet, but they announced the top line results and they thought it was positive, but didn't give a whole lot of additional data. So we'll wait to see kind of more details on that and on the side effects too. Next, we'll talk about a dopamine agonist that's new on the market called tavapadon. It's a little bit different mechanism of action compared to other dopamine agonists because it targets the receptors that are involved in the movement symptoms of Parkinson's, and it avoids the receptors of dopamine that can cause some of the side effects like hallucinations and impulse control problems. So that could be a really helpful thing if it holds up in trials, right? It's just taken once a day by mouth, and they've done 3 phase 3 trials, and we'll talk about the results of those on the next slide here. So they were named the TEMPO trials. Basically, the first 2 that were done were in people with early Parkinson's disease, and it was the only medicine they were taking. Both of those ones showed clinically important changes, improvements in the movement-related scores by 9-10 points compared to placebo. And then the third trial was in people with more advanced Parkinson as kind of an add-on to the medicines that they're already taking. And again, that one was statistically significant and showed an improvement in on time by 1.1 hours per day. Again, we're still kind of waiting on some more details of this, including side effects. But if they're favorable, these results seem to be very encouraging to me. So as far as I could ascertain, it looks like the company is going to be going to the FDA and potentially seeking approval later this year. So I'm hopeful about this therapy and that we might have a new medication option that we're talking about this time next year. Okay, for this last section, we'll talk about a few things that you might have heard about in the news, and we'll try and go through some of the data on them. The first one we'll talk about are the GLP-1 agonists. So these have been approved for a long time for things like diabetes, type 2 diabetes, and then more recently for weight loss medications. And then just in the last year, there have been several trials that have been published that have investigated its use in people with Parkinson's disease with the hypothesis that it might slow down the progression of Parkinson's disease. So we'll look into the results that were published here in the next slide. Basically, the first one that was studied called exenatide had some promising results in a phase 2 study. However, unfortunately, a phase 3 study that was just published this year showed no difference after 96 weeks of treatment. So that was a pretty disappointing result. They also tested kind of a long-acting form of this same drug and found similarly no difference after a 36-week treatment period between the active drug and the placebo. So that was kind of disappointing results all around for the exenatide studies. For the lixisenatide, that was a positive trial. It reached statistical significance with improvement in those motor scores at 1 year of treatment. However, we've been talking about what matters to patients, that minimal clinically important difference. And this one only showed an improvement of 3.08 points on that movement scale, with the important difference being 3.25. So almost on that cusp. Side effects would be something to think about. Is that maybe clinically important difference really worth the side effects that you might get? So the side effects in this general class of medications are things like nausea, decreased appetite, and weight loss. Those would be unpleasant and uncomfortable side effects for anyone, but can be particularly problematic in people with Parkinson's disease who might already struggle with nausea due to things like gastroparesis or nausea from carbidopa-levodopa. Might be particularly problematic for people who struggle with a suppressed appetite or who struggle to keep on weight. And and more weight loss can be a problem in people with Parkinson. So these side effects are really important to think about in people with Parkinson's disease before you push too hard for these sorts of medications. Okay, next we'll talk about marijuana and related products because we'll often get a lot of questions about this. So when we think about marijuana, there's kind of two active components. One of them is called THC, tetrahydrocannabinol. That's the psychoactive part of the marijuana. And then there's CBD or cannabidiol, and that's the non-psychoactive part. Thinking back to 2020, there was this study of a synthetic THC, so the psychoactive one, called nabilone. That was a pretty good trial design, randomized, controlled, placebo and blinded, but it was just a phase 2, small number of people, only took the drug for 4 weeks. And that one showed no improvement in the movement-related symptoms, so no improvement in tremors, no improvement in dyskinesia, stiffness, slowness. But it did show that maybe it would help some of those non-motor symptoms like anxiety and sleep problems, which could be a potentially helpful thing for a lot of people with Parkinson's disease. And then just in the last year, we had another study that was published slightly different results here. So that was 61 people. They only took this drug for 2 weeks, and it was a combination of CBD and THC. So both of those active components of the marijuana, and it was in an oil form. Basically, they showed a non-significant change in those movement scores. So it was kind of a negative trial for those primary endpoints. And they did show several important side effects that we'll highlight here. So over half of the people felt dizzy, more dizzy, which can be a problem in people with Parkinson with maybe low blood pressure. They felt relaxed, which can be a good thing. They were more tired, and then they also had a lot more cognitive changes, which can again be a big problem in people with Parkinson who are already struggling with some cognitive changes without the additive effects of medications. So my takeaway from these marijuana-related trials are that number one, we don't have any phase 3 studies. I don't think that our evidence is strong enough to make any recommendations either way about marijuana therapies, and certainly not strong enough for me to recommend them to people as a prescription. And I think that more research is needed on these therapies. We need to figure out what are the safety profiles of these compounds, what are the side effects, what are the benefits in movement and in non-movement related symptoms. What's the best way to administer these drugs? Is it by mouth? Is it by oral? Is it by smoking? Those things all need to be figured out. And then the relative composition of THC and CBD also are important things to be able to clarify as we move forward with these trials. What's keeping us from moving forward with these trials? A lot of it is federal regulation. So the DEA places very strict limits on how we can study these in scientific trials. So it can be very challenging to plan and conduct these sorts of trials in the United States. All right, so thank you for sticking with me throughout this. I appreciate your attention. We'll just kind of go over a summary of what we've talked about today. So first, we talked about one new drug on the market, and that one's called Crexont. It's a new formulation of carbidopa-levodopa. And I think it could be helpful, and people might be able to take it less frequently throughout the day. We have 2 new pumps that are on the market, Vyalev, which delivers carbidopa-levodopa, and Onapgo, which delivers a dopamine agonist called apomorphine. We've got a lot of phase 3 trials that are ongoing, so a lot of active research into the field and new therapies that I think are going to be coming on the horizon very soon. We talked about GLP-1 agonists that at one point showed some promising results, but these recent trials have been really not borne out a lot of this excitement that was initially brought up. And then finally, we talked about marijuana and related products, really concluding that we just don't have enough information to be able to recommend either way on this therapy. Okay, so coming to the end here, thank you for bearing with me through all this. I hope these studies and these updates on new developments leave you with some new hope and with some excitement about things that are coming in the field of Parkinson's disease. Thank you all for your attention, and that's all. I'd be happy to take questions later.
We'll be starting in the next one in just a few moments. I'm going to go check on the other room. In this room is going to be wires or waves, DBS versus focused ultrasound. In the Parkinson's 101 with Dr. Burke. And in the other room is going to be Parkinson's does that with Dr. Ramirez, Adolfo Ramirez in the room to the right over there. But let me go check that room and we'll be starting right back up. Okay, I'd like to introduce Dr. Rachel Burke, another one of our awesome senior fellows. And I already mentioned the title, so welcome, Dr. Burke.
Good afternoon, everyone. Nice to see everybody here. So like Amanda said, I'm going to go ahead and talk to everyone about wires or waves, DBS versus focused ultrasound. Can you all hear me a little bit better now? All right. And how about now? All righty. So just to start off, I'd like to acknowledge the Francis and William Smallwood Foundation, as well as the Dorothy Mangurian Lewy Body Dementia Foundation for supporting my fellowship through my time here at University of Florida. So today I'll just give a brief outline of what we're going to talk about. So we're going to talk about when do we start to consider these advanced therapies, who is really the best candidate for these therapies, and we'll touch base on kind of the history of how we came to these therapies, briefly mentioning our conventional lesioning therapies, then DBS, focused ultrasound, and then we'll get into the who should choose what and go from there. So advanced Parkinson's disease is difficult to define. Many people have tried to put scales together, put resources together to really kind of quantify who is advanced in their diagnosis of Parkinson's disease. But ultimately, what this comes down to is your clinical functioning through your day-to-day. How are you handling your symptoms and able to move through your day-to-day life? And so with that in consideration, we start to think about who of these patients who are having a harder time managing their symptoms and having a harder time through their day-to-day, who should be given these options. So typically for these advanced therapies, we want to see someone who's having a good, clear response to levodopa therapy. I'll give the little caveat there is that sometimes people who do not respond from a tremor standpoint to levodopa therapy often do respond very well to these advanced surgical therapies. So we have a little asterisk next to that. But for things like stiffness and slowness, that typically responds very well to levodopa. You're going to have a good response to these advanced therapies. We want to make sure that we're in the kind of opportunistic window where we have these troublesome complications, either from the medications that are limiting the amount of medicine that you're able to take, things like dyskinesias, things like nausea, or just intolerance to the medication, or you're having to take it so frequently and able to maintain that on status of your medication, but not so disabled that we're in the phase of Parkinson's that's a bit refractory to these treatments. So we try to assess that nice therapeutic window where someone is at the point where they're disabled enough, but not so permanently disabled from Parkinson's disease that they can have a true benefit from these surgical therapies. The other things that are important to know are having the best expectations for what these therapies can really provide for you. And so these are excellent strategies to help manage a lot of symptoms from Parkinson's disease, but unfortunately, they're not a cure for Parkinson's disease. And so I think it's important to always make sure that we're understanding we can expect significant benefit and improvement in quality of life with these therapies, but it isn't going to take away the Parkinson's disease. And so making sure we have that expectation kind of well managed and understood before going into the surgery is a huge factor in making sure that we're setting you up for the most success in these procedures. The exclusionary criteria really for who can have these therapies is we want to make sure that your diagnosis is clearly a diagnosis of Parkinson's disease. We have not found that deep brain stimulation or focused ultrasound is helpful in secondary causes of Parkinsonism or atypical Parkinson's disease. So things like MSA or PSP, they don't tend to respond as well or have great success with these advanced surgical therapies. So we don't perform for those conditions. There are some factors and features of Parkinson's disease that someone might be experiencing that give us a little bit of pause when we're considering these therapies, and those are namely pretty advanced cognitive impairment or active psychiatric issues. They're not absolute contraindications to having these procedures done, but they are things that we take into consideration, and we really have to weigh more heavily the risks and benefits of undergoing a surgical procedure when these are the more active features of your Parkinson's disease. And so I told you that I put a little asterisk next to the tremor. So we're going to continue to think about this. Why, if my tremor doesn't respond to levodopa, why would it then respond to stimulation? And so I'm going to have you guys hold on to this thought, and we're going to talk about that in a future slide here. So in going through the history of how we get to DBS and focused ultrasound, we start back in the beginning of lesional therapies, or what we refer to colloquially as the conventional otomies. So these include things like thalamotomies, pallidotomies, and subthalamotomies. All that really refers to is the particular type of the brain area that we are performing a lesion therapy into. And so we can see kind of the different targets here and what the typical surgical setup looks like for patients who undergo this otomy therapy. And so what this is really helpful for is tremor pretty exclusively. And so these therapies are typically performed only on one side of the body because they do have higher risks of side effects when performed bilaterally. The different targets that we focus on in these conventional therapy or in the conventional otomies are more focused on tremor control. We'll look at the thalamus, which will not really impact so much the stiffness or the slowness of movements on the side of the body compared to the pallidum or in the subthalamus as well. There are also some more persistent risks of things like persistent dyskinesias that can develop when you're performing a lesional therapy in the subthalamus. And so that's something for us to keep in the back of our minds. As we moved on and as time has progressed, we've developed kind of more advanced surgical techniques on how to better address the symptoms that come up with Parkinson's disease. And so I'll lead us into our deep brain stimulation right now. And this is just a timeline of how we got to DBS where we are today. And so I'll highlight a couple of key dates. So starting back in 1939 is when we really first started to see big surgical treatments relating to tremor. In 1953, we actually saw the first kind of pallidotomies being performed to help alleviate tremor specifically. And then in 1968, carbidopa-levodopa, as Dr. Curry has mentioned, came onto the scene, and we really kind of started to see surgical approaches to tremor, to Parkinson's disease starting to take the back seat. And that went on until about the 1987 when the first deep brain stimulation surgery was performed in the setting of a patient who had essential tremor. And then we move into 2002 when we finally have FDA approval for deep brain stimulation for Parkinson's disease. So when we're talking about stimulation in the brain, we need to know about the kind of pathways and the circuits that we are stimulating. And so whereas the medications can play roles in these various kind of aspects of the circuitry, what the stimulation is looking at is how can we modulate the way that the neurons or the cells in the brain talk to each other to give you a smooth movement and to reduce the tremor that you're experiencing. And so this kind of complicated picture and pathway here involves structures called the basal ganglia. the thalamus, and the cortex. So that's basically your big loop of how you move smoothly through the world in a very kind of crude sense of the way. So when we do something like deep brain stimulation, which is the most frequently performed surgery for Parkinson's disease therapy, what we are doing is we are implanting hardware into the brain that provides an electrical stimulation to try to modulate and provide some stabilization to the aberrant firing networks in Parkinson's disease in that same kind of circuitry pathway that I showed you before. What we look for is that regularization of firing to try to cause smoothness of movement, coordinated movement, and reduction in tremor. So remember our friend who asked if my tremor doesn't respond, and it all comes back to that pathway and those structures that I showed you. The medications play specific roles in some aspects of that, but they don't modulate the whole pathway. And so that's why when we say someone whose tremor doesn't respond to levodopa, we expect it to respond to stimulation or to modulation, is because we are modifying that pathway at a different point from where the medication is reaching. And so that's why when you read, symptoms that respond to levodopa will respond to deep brain stimulation or to a focused ultrasound, but my tremor doesn't, this is why. And so several different groups have been kind of looking into how and what specific aspects of these pathways is this deep brain stimulation causing that modification and affecting tremor in comparison to levodopa. So there's a lot of ongoing work looking into that pathway now. So to give a little bit more of a visual of what does deep brain stimulation look like? So we have our patient here who has an IPG, which is the pulse generator, or you can think of it almost like a pacemaker or a battery in their chest that's planted under the skin in the chest. There's a wire that comes up the neck behind the ear, and it connects to the two electrodes, if you have both bilateral stimulators placed, that lead into the brain. There's a couple different targets that we can see and use for deep brain stimulation. In Parkinson's disease, the most common targets are the subthalamic nucleus and the globus pallidus interna. Those are both that structure in that basal ganglia area of the brain that I had mentioned earlier. In some cases, we will see in Parkinson's disease that you can perform deep brain stimulation in the thalamus, but typically that's something that we see a little bit more common with essential tremor type tremors. And so just to highlight again, these are those specific areas that we highlight and target with our deep brain stimulation. So when we look at deep brain stimulation as compared to medical therapy, as defined here, BMT stands for best medical therapy. When we look at kind of rates of how people have done and how their symptoms have been managed with time, ultimately, we see non-inferiority between deep brain stimulation and best medical therapy. And in this particular review and study, they actually found that people tended to feel that their motor symptoms improved more so compared to best medical therapy. So when we're considering deep brain stimulation surgery, we want to make sure, again, that we have an appropriate candidate for it. That means understanding what we can reasonably expect to improve with the deep brain stimulator, and that we have a supportive environment that someone is going to really be able to flourish in and thrive after the surgery. This is a brain surgery, and it takes a little bit of time to recover from it. There is ongoing programming because the deep brain stimulation is not a one-time procedure and then things are kind of optimized out the gate. It takes time to really optimize the settings and to control the stimulation that's going to give you the best outcome with your deep brain stimulation therapy. And so making sure that we're aware of kind of the back work after the fact to really optimize our success with this procedure here. The way that we have at UF set up our deep brain stimulation program is we have you kind of meet with everyone and anyone with our team, with our therapists, our social worker, our speech therapists, our neurosurgery team, our psychiatrists, our neuropsychologists, and we're really looking for, do we have the best chance of helping you with this surgery, or are we putting you at undue risk? And so those would be the things where someone has more severe cognitive problems or some active psychiatric illnesses that might pose some complications to therapy down the lines. And do we have symptoms that we expect to get better from deep brain stimulation? And so those symptoms that we really think are going to improve are going to be things like rigidity, bradykinesia, dyskinesia, tremor. There are targets that we can focus on that can aim to reduce the medication burden that people take. And there are also sometimes targets that can help with some of the more axial signs. Those are your things like tripping, falling, being a little bit more midline, having problems, less so with tremor, things like that. But we caution with DBS that it does not often help with cognition. It does not often help with falling, and it does not help with balance. And so those are important factors to really keep in mind when you're kind of deciding, what am I going to use my deep brain stimulator for? If that tends to be the more bothersome aspects of your Parkinson's disease, this is not necessarily the best option for you. And it's something that we have to kind of discuss with the rest of the team to make sure that we're not putting you at more undue risk as a result. So some of the side effects of this procedure in the acute setting, when you have the surgery performed, there's risk of hemorrhage, there's risk of stroke, small risk of seizure, urinary retention. These symptoms are relatively low risk when we go into the surgery. They're uncommon, but they are things that can happen, so it's worth kind of noting them. The other potential side effects of the deep brain stimulator are any infections to the hardware, because as I mentioned, we have multiple pieces of hardware that are implanted into the body and that remain in the body. So there's risk of infection there. There can be erosion of the skin from the area. And so we can always keep a close eye, kind of checking on those things, meeting both with the surgical team and the neurology team after the procedure is completed to make sure that we're minimizing any of those risks. And then in the long term, when we've looked at kind of patients who have had deep brain stimulators and followed them out, some people have noted that they feel that their balance had gotten worse after the procedure. Some people have noted that they had some fatigue or felt some depression. A lot of the time that comes from kind of expectations of this was going to make a much more dramatic benefit in my symptoms than what ended up happening. And so we always advise patients of that. And that is one of the reasons that we stress the multidisciplinary pre-surgical evaluation so strongly, to really make sure that we're being as transparent with people as possible as what we can reasonably expect to improve with deep brain stimulation. So right now, there are 3 different companies that are offering stimulation equipment and devices. They each kind of have their own unique flavors of things. So their newer kind of outcomes are the sensing and streaming of brain signals that's been done by Medtronic. They've also started releasing a new program called Adaptive, in which the leads and the pulse generator are able to respond to the signals that are firing in your brain and adjust stimulation based on those parameters. With Boston Scientific, they have developed a new technology that they can use AI to merge with your MRI brain and suggest stimulation patterns based on where the lead ends up in your brain. And then with Abbott, less of a newer feature now, but they have the ability to have remote programming where you don't have to come in person in clinic for your sessions. And as long as you're able to connect on Wi-Fi, you could be in the comfort of your home and the clinician could be in their office and be able to adjust your stimulation settings that way. So we'll move on from deep brain stimulation and into focused ultrasound. And so again, we'll start with the history of focused ultrasound. Really, evidence working with ultrasound therapy came out of how it was being used to remove and treat tumors in patients with cancer. And that was happening around 1990s. Starting in the early 2000s, we started to see how could this be used as a therapeutic delivery mechanism because it can disrupt the blood-brain barrier, which I'll highlight a little bit later, and help with medication delivery directly to the brain. Then in about the 2010s, we started moving into, okay, how do we use this as lesional therapy to help control things like tremor? And then back in 2013, we can see that started being used in essential tremor. And now we've gotten to the point where we are FDA approved now for focused ultrasound unilaterally for Parkinson's disease. So the biological effects of focused ultrasound in the top row of pictures here, what it shows is kind of thermoablation, which is basically how we perform the lesioning of a specific area of the brain without having to actually cut into the brain. So there's no going through your skull, no going through the other brain tissue. You're able to target specifically where you want the lesion to appear, and you're able to lesion that way. The middle photo on the top just shows some blood-brain barrier disruption. What this essentially means is the blood vessels going to the brain, they can lower the permeability or the way that medicine gets through and can deliver directly into the brain by being disrupted with the ultrasound. And then the last photo in that top row just shows the kind of way that they don't have to go through an incision into the brain to be able to deliver that therapy. The bottom row of photographs here is just providing some extra evidence of different types of therapies that could be delivered with the focused ultrasound. So things like using ultrasound sensitive nanoparticles to cross the blood-brain barrier and deliver specific medications that way and move on from there. So there have been multiple applications of focused ultrasound for the brain for different conditions, but we can highlight more towards the front of the brain in the picture here where that lesion for specifically Parkinson's disease is going to come into play. And that is still in that basal ganglia. So it's the same area of the brain that we look at with DPS, but now we're looking at it with focused ultrasound. And so to give a visual representation of what that looks like. So in that top left photograph, we have our kind of classic setup of what a patient would look like undergoing the procedure. So it is an MRI guided ultrasound that is used to help target specifically the exact location in the brain that we want to lesion. The bottom three pictures here, what I can show you is the one on the left is a lesion that was made one day after the focused ultrasound was completed. The middle one is 1 week after the lesion was completed, and then 2 months after the lesion was completed. So you can see that there's a little bit of kind of extra white signal in that middle area of the brain. Does this have a pointer? No, this doesn't have a pointer, I'm sorry. But that starts to go away with time as the brain heals, but the lesion is still remained, and you can see symptom improvement from there. The other photograph, again, is just giving a representation of if you were to kind of slice the top of that MRI machine open and look straight down, this is what you would be seeing the patient looking like. So again, a little bit more visual representation of how we use the coordinates from the MRI to target specific areas in the brain in order to provide and deliver the ultrasound to that specific area in the brain to help relieve symptoms. So the way that we actually do the lesioning, so there's no incision into the scalp, but we start to spin the MRI. We have our coordinates based on the MRI. We deliver the ultrasound and we test to see if there is symptom improvement. This will continue until we start to notice the complete benefit of what we're looking for. And we'll increase kind of the sonication or the dose of ultrasound delivery until we start to see the benefit that we are looking for. So one of the interesting things about ultrasound is it's described as a less invasive surgery. However, compared to the DBS, we're causing a more permanent lesion in the brain. And so I sometimes have pause before I say that this is a non-invasive procedure, because whereas DBS has modifiable changes based on how you deliver the stimulation and how you program your settings, with focused ultrasound, you have the lesion, and once the lesion is done, there is no changing that lesion. In the past, there have been other kinds of forms of radiation and ultrasound delivery for lesioning and therapy like this, including gamma knife. The main differences here are that with the MRI-guided focused ultrasound, we're not delivering radiation to you. This is we heat up the ultrasound, and it's the heated thermoablation that causes the lesioning versus the radiation-induced lesioning that we see here. So when we've looked at outcomes of how people have done after having focused ultrasound, we have seen significant clinical improvement, especially compared to placebo in patients over time, and particularly with tremor. And so this was one of the landmark trials that really gave us the go-ahead to say, you know, focused ultrasound is a really viable option to help with some of the symptoms of Parkinson's disease and should be considered as one of the advanced therapies for it. So again, we start to think about the different targets that we're looking at, and they really come down to the same as what we would look at with a deep brain stimulator. What we end up deciding largely is based on what are the most bothersome symptoms and features of your Parkinson's disease, and can we go in and adjust the target based on what you're experiencing. So some of the limits of focused ultrasound, as I had mentioned, is that this is a permanent lesion that forms. There is less follow-up data, as it is a newer procedure for Parkinson's disease. We have significantly less data on the outcomes in the long run compared to deep brain stimulation. And that all just comes back based on the timing of when these therapies became available and knowledgeable to us. The benefits are that you don't have to have an incision into your scalp. We don't have to have you in the hospital nearly as long, and we can see more immediate benefits from this type of procedure than we can with the deep brain stimulator, where with that, we're having you follow up with us pretty regularly to optimize the stimulation parameters and settings. And so there are definitely gives and takes between both deep brain stimulation and focused ultrasound. One of the other things that I'll argue about focused ultrasound is that for someone who maybe has a few more medical comorbidities or is not in as great of health otherwise, This is a more gentle procedure in the sense that we don't need anesthesia. You're not having to stay in the hospital as long. There are some fewer risks there. So someone who's maybe not the most ideal surgical candidate from a medical standpoint might select focused ultrasound over DBS. The other thing that I will note, though, is that right now for Parkinson's disease, focused ultrasound is only approved for one side of the body. So you can't have both sides done. And for someone who has more advanced disease, if it's unilateral, this could be great. But if someone has more advanced disease and it's affecting both sides of their body pretty dramatically, we can only address one side of the body. And so you're not going to end up reducing your medications because you're still going to have to address your symptoms from the other side. And these are kind of the important things to think about when you're discussing with your neurologist and with your neurosurgeon about which procedure should I get. So I jumped the gun a little bit talking about choosing therapies, but a lot of this is what we kind of come down to. And in this paper that was published also looks at some of the continuous levodopa infusion devices that Dr. Curry had mentioned earlier today. But when we look at focused ultrasound and deep brain stimulation, we can see that there are kind of the differences that I mentioned, namely being unilateral versus bilateral, whether or not you need to be have an incision made for the surgery, whether there's a permanent lesion versus an adaptable lesion and a modifiable benefit or stimulus. Those are all kind of the things that we think about. And so when we look again at patient profiles, if you Google who should get focused ultrasound, who should get deep brain stimulation, you're going to come up with a lot of charts that look like this through Google. And what we really stress for these things are the symptoms that get better are the ones that get better with things like levodopa or your medications, with the exception of tremor for the reasons that we talked about. And if that's kind of the mantra that you have in your mind going into your kind of surgical evaluation, this is what we're thinking. Things again that are not ideal for focused ultrasound or for deep brain stimulation are again those features that don't really respond to levodopa, or those things like balance problems, speech problems, cognition. We really don't expect those to improve, and they can actually get worse as a side effect of either focused ultrasound or deep brain stimulation. And so we always want to make sure that we're cautioning and reviewing those symptoms before we proceed to surgery. So just a quick, easy table for you guys to see when we break down and compare deep brain stimulation and focused ultrasound. Ultimately, our goals are we want longer on times, and we want symptom control. And so when we compare the two, both can deliver those things, but only one is able to be delivered to both sides of the body. But one of them is a lot of an easier procedure, I would say, to tolerate in terms of the lesioning. So disabling motor complications, DBS is really great at that. Focused ultrasound can be helpful, but I would say DBS wins out when you're comparing the two. Refractory tremor, either option is a great therapy. And then with the accessibility of these procedures and these advanced therapies, we do still see thalamotomies, pallidotomies, and those conventional otomies, as I had mentioned in the beginning, being offered as they're more widely accessible to areas where people have less access to care, less access to follow-up, and less access to things like that. And so in summary, what's really important is that this is an interdisciplinary approach. To select the best target, you really need to be meeting with your team. As Dr. Hess had even mentioned, an interdisciplinary team makes all the difference. Making sure that the physical therapists are talking with the neurologists, are talking with the neurosurgeons, and that you're all communicating clearly to each other to select the best target for you and to select the best procedure for you. And so in summary, DBS and focused ultrasound are both very effective options for treating Parkinson's disease. The success of the therapy really depends on identifying kind of ideal candidates for that therapy. And then choosing the therapy really does require the work of a team and you, because what this is important for at the end of the day is these are your symptoms that you're experiencing, and we want to make sure that whatever procedure we go with is really highlighting and focusing on what's going to improve your quality of life. And I think I spoke really fast, but I am finished up here. So if there are any questions, I'm happy to answer them during the panel here. And it was lovely to see all of you guys today.
So yes, please write your questions down on the pieces of paper that are on the centers of your tables, and we'll come around and pick them up and get them ready for the Ask the Doctor panel. You guys in here can actually start getting your lunch if you want to start headed down the back here, and you can pick up a ham, turkey, or veggie sandwich. If you reserved a gluten-free or veggie sandwich, I will be standing right there over those, and I have those set aside for those people. But you're going to grab a box, you're going to put a soda into it, or a bottle of water, pick a cookie of your choice, grab a banana or anything else. There's still some coffee left, and come sit back down and we'll get ready for our Ask the Doctor panel. Yes, please raise your hand if you have questions that are on your table, and we'll come pick them up too. So. Or if you need somebody to bring you your lunch, if you've got mobility issues, just raise your hand and we'll be happy to help you. I've got great volunteers.
My daughter is riding today, 6:30 left to the ride. She's gonna try to stay over tonight. Try to get some work done today. What are the? What? Oh. Where do you go? And then have fun.
Oh, no, that's it. Yeah. So this one will be for the side.
Nick, I have a question for you. This is the Nick. Is there one? Yes. Sure. I don't remember what the name of the trail that we were planning on doing. Anybody else coming up? Hey, there's time for the other side.
Hello. We're gonna start the questions in just 2 or 3 minutes while the last few people are gathering their lunches. Does anyone have a question on their table that they want us to come and gather from you? Can you raise your hand if you do have a question on your table that you've written on that paper that you want to send up? You might think of questions as we go, and if you do, just write it on the paper and just raise your hand and we'll make sure someone picks it up.
Yeah, I can see sort of be that, but I do, it also has that.
So is Alabama tonight? Tears is good. Yeah. What could happen?
You know what? I can give her.
Tears played for somebody else before. For Source. Tears. I think he's always been in Alabama. Tomorrow is Tennessee, Houston. We need another chair and VK. You need another chair. Michigan State. Michigan State might beat Auburn. Thank you. Regarding the slide that showed environment incidents of toxins versus PD incidents, what's your guess about the small? Something low PD, low. Do you want to give any? Small. Got everybody here. Yeah, okay.
We don't have yet. Let's see. Yeah. Hey, Chris, why don't you, what are you holding? Stretch it out, and we can give them. Okay, take your time if you're still getting settled. We're going to go ahead and start. This is one of our favorite parts of the day and our concluding session, which is lunch, and also the Ask the Expert opportunity. So please don't be shy. If you have a question, I can almost promise that someone else in the room wonders the same thing. And you don't have to write your name or anything. You can just send it anonymously up to the front. And so we'll kind of go ahead and answer the questions that we have so far. It looks like we have 2 or 3 questions for Dr. Dorsey, so we'll let you start with answering one of them.
Thank you very much. Delighted to be with all of you. Thank you for all the kind words. If you didn't get a copy of our book, Ending Parkinson's Disease, we still have more copies. We're delighted to give you them. And if you haven't ordered our new book, please do so. One question is, why does it feel like why does it feel like you are a singular environmental medical voice in the Parkinson's community? Where are the other scientists to help support these facts? I think we're absent without lead. I think it's a great shortcoming of our profession that we're unaware of these chemicals. I trained at top institutions like Michael, like Chris, like Irene, and we weren't taught this. We were taught, if anything, to be deeply skeptical of environmental causes of diseases. I still remember the occupational health lecture. You guys probably had the same one. We were told like carpal tunnel syndrome from people using jackhammers. I think there's also reasons why we're ignorant, because I think companies don't want messages to get out and suppress it. They also attack scientists, some of my peers. I've gotten emails from them being attacked just this past week. So it's not a popular position to take. I also think we live in an era that's defined by genetics. So one of the great scientific advances of the last 50 years is the identification of DNA, and that's led to huge investments in genetics, and those investments have paid huge dividends. A lot of the diseases that we care for, Huntington's disease, spinal cerebellar ataxias, all these rare diseases have huge genetic components to it. But if you think about it, genetics can't explain why people get common diseases. Things that are really common: heart disease, lung cancer, breast cancer, prostate cancer, emphysema. These can't be due to genetics, because if they were due to genetics, they would have already been screened out before the present time. So I think, one, we live in a genetics era that's provided advances, but genetics as a whole only explains 20 to 30% of health. We're not taught it. I think some of that ignorance is intentional. And then people get attacked for speaking about these causes. So I think those are all reasons why, and we all suffer because of it.
Thank you. Dr. Burke, can you share?
Okay, so this question is, are the potential long-term effects of DBS that were mentioned attributed to their surgery or to long-term progression? And so with side effects from DBS, typically what we'll see is any complications that happen in the OR, in the surgery, we know kind of pretty soon when you come out of the operating room. And those ones can be attributed directly to the surgery. With things like dysarthria or some imbalance problems, those are a little bit harder to tease out. What we often will do is monitor those over time and see if changing your stimulation parameters affects those symptoms at all, to say whether or not this is a result of the stimulation from DBS or is this progression of the Parkinson's disease itself. So it's a little bit of a both answer to that question, but things that we kind of have ways of teasing out in the clinic with you and watching over time.
Yeah, no, I completely agree. And I think that it's important to remember that when most of the investment when you have deep brain stimulation is upfront. One of the advantages of the stimulation over other techniques is that if you turn off the device, the symptoms induced by the electricity will go away. So initially there was a lot of interest in seeing if DBS will have a direct effect on slowing down this progression. We don't think that that's the case, but certainly the long-term benefits of DBS change some of the expected trajectory of the progression of motor symptoms, as DBS continues to be very effective in treating slowness, dyskinesia, and tremor even long-term. But some of the other symptoms that occur with the disease may not be treated, and some of the problems that you mentioned, like speech and balance and problems with gait, are more likely and most of the time related to progression of the disease. I will do this next question. It's also a question about neuromodulation and for the treatment of headaches. And is this something that could be used specifically focusing on orthostatic hypotension? What I would say about this is that neuromodulation per se, not necessarily deep brain stimulation, has been tested in patients with headache, in patients that have headaches, not necessarily in Parkinson's. And there are a few techniques looking at stimulating the nerves to try to help with refractory headaches. Deep brain stimulation per se has been tested also in patients with headaches, and that has not been as successful as you would expect. And when you focus on orthostatic hypotension, there's no, as we know, there is no clear direct effect of deep brain stimulation on the autonomic symptoms, including the orthostatic hypotension. It's not uncommon to have improvement in orthostatic hypotension if that was caused by medications before surgery, because a lot of the things that we can do after surgery rely on potentially making changes on your medications that we couldn't do before surgery, because now the surgery is really helping to manage those symptoms. So a common example is that if you are having low blood pressure because of certain medications for Parkinson's, after surgery, we may be able to get you off of that medication. You don't need it anymore because now surgery is controlling your tremor. So indirectly, we could see effects on some of these symptoms, including orthostatic hypotension.
Sure. Yeah. All right. So this is a really good example. You guys asked the great questions and some of the tough questions, actually. So the question I received is there a trial going on to introduce a drug into the brain to change some of the neurons into dopamine-producing neurons? So highly technical question. I'm going to answer a couple different ways. Number one, I'd say, no, there's no pill that we have currently that can tell your other brain cells that don't produce dopamine to produce more dopamine yet. There are a couple other ways that people actually there's ongoing research here to work on this. So one way was to introduce those cells via what's called stem cell or even embryonic stem cell or other ways to produce stem cells to put them back into the brain. So there are actually a lot of efforts on that front. Probably many of you have heard stem cells have proposed to do anything, fix anything, except for the kitchen sink, basically. So all disorders have been looked at, particularly neurodegenerative disorders, to find ways to. Stem cells basically are those things that have this potential to become any kind of cell. Okay. And there are different sources of them. So embryonic was one of those. Of course, there are ethical issues with collecting those. Plus, embryonic stem cells from other people might induce some sort of, we call immune reactions, host reactions, and you have to use some immunosuppression for that. But there are different kinds of stem cells nowadays, even ones that you can derive from your own body. We call those autologous stem cells. You can get them from the fat or other even stem cells or other areas of the body as well. And those are your own stem cells, and those basically you don't have reactions to. And they can also be introduced into the body too. However, there are a lot of challenges for this. So I want to really emphasize the challenges issues. You can't just put stem cells into the body and expect them just to become the brain. I kind of liken it a little bit to basically taking gas and throwing it on your engine. It's not going to go in the right place. You got to put gas into the gas tank to get it to the right spot. Same thing kind of like with a computer. If you put a part, you can't just throw it in the computer box and hope that it's actually going to find the right place for that part to actually make the computer go. So the brain is a really complicated organ. You're born with it. It's developed over time. Making those complicated connections that allow you to behave appropriately takes a lifetime. And to regenerate those is a huge, huge challenge for us. We do hope that stem cells can eventually get there, but there's a long way for us to go. There are other benefits from stem cells. People are doing a lot of research. Stem cells may produce, we call humors or hormones that might actually help some of those brain cells survive. So there are other effects that might be helpful in the brain potentially, or even other organs actually. So other things that stem cells might be doing, but we're still at the research stage with regard to stem cells. There's a lot of new research ongoing with stem cells. We can actually engineer stem cells. We can tell them these days, so it's really neat. We can tell them to actually become specific neurons. And we can even tell them not to be just neurons, but to be, we call those dopamine producing neurons. And then we may be able to put those back into brain, but putting it back in the brain requires some surgical therapy to do that. So it's a complicated process. It's definitely not a pill yet. So another half of this, or another aim of this kind of question actually is, can we tell your brain cells to become, so there you have brain cells, can we tell them to produce dopamine? And so another way that researchers have been looking at, and this has actually been done over a number of years, and even currently, is to genetically change the genetics of a cell. Okay, by introducing some genetic information. And we have techniques like that. Ways to do that is actually by using a virus. So viruses that have been engineered not to cause disease, like the cold virus, but they don't cause the cold. And you can use those viruses to introduce genes to regulate the way a cell functions. And you can actually, there have been researchers have developed different ways to introduce genes to produce dopamine. So some of the enzymatic pathways that either make dopamine produce more, as well as maybe reduce the breakdown of dopamine. So basically like stopping up the drain. So dopamine can't be degraded. And so people actually have done this so well, they've even introduced 3 different genes in a virus into the brain and show that it actually does have some potential for working. But there's a lot of research, okay, that needs to be done. So I do tell folks, we are sort of at this verge of getting there, but there's a lot of more research. There's so much potential with different ways to introduce genes, stem cells. You can go out there in the public and get stem cells. You can buy them. There are a lot of people out there, even in Florida, there are places where you can get them. Just understand these are still research-based. All of these therapies are not FDA approved yet. They may have FDA approval to do the procedure, but not necessarily approval saying that this treatment is going to work for you. So often we all warn folks not to be taken. If you're going to do a trial, that you should be compensated. There are risks to all these therapies. So just be careful going into, ask us about them. We can discuss the pros and cons for them. But we don't want you to be taken if you're going to be part of a trial. And there actually are some stem cell trials, and even some of these new types of stem cells that are coming. Our center is actually looking into participating in one of those trials. Yeah, a couple of them actually. Yeah, a couple of them. Yeah. And they are very promising. So we're going back to stem cells and looking at them more carefully. They were done many years ago with great potential, but people did have side effects from some of these therapies like dyskinesias. And now we think we have the engineering techniques, the biochemical techniques to actually make these cells, totally fine tune them and make them much better. So long story, but a lot of potentials there.
Thank you. Dr. Oken, did you have any more comments about that? I know we had 2 or 3 questions about stem cells.
Yeah, so there were a couple of questions here on stem cells to treat and reverse Parkinson's and stem cells and Parkinson disease. And so building on what Dr. McFarland so eloquently summarized, I will just add a few things. First of all, raise your hand. Anybody like podcasts in here? Anybody listen to podcasts? You podcast listener. So if you're a podcast listener, there's a podcaster named Laura Beal who has a podcast. This is kind of dark, okay, called Dr. Death. But it wasn't that podcast that she's an investigative reporter. Her father had Parkinson's disease and was interested in stem cells. And so she actually did a podcast called Bad Batch. And so BAD batch, BATCH. And she actually went around as an investigative reporter and asked all the questions that you and I would ask about all of these places that are all over the world, all over the state of Florida, all over every province, every region, every prefecture, in every country, people offering these stem cells and what it all means. And sort of at the end of that, Nick, she kind of comes to this conclusion that that this is more of a for-profit industry that isn't necessarily safe, and that there's also a whole bunch of people that can afford it and pay a lot of money for these things. And they thought, well, it can't hurt anything. And then she talks about a lot of the cases where actually people did get hurt and go blind and have tumors and things like that. And so we definitely, not to be dark on the stem cell issue, just be a little bit careful and make sure it's a research study. The Parkinson's Foundation does have a set of guidelines that if you're considering stem cells, that you should always be thinking about and thinking through to make sure that you stay safe. Having said that, in the next book that we were writing, we got the opportunity to interview experts from all over the world. And so we did several dozen interviews, and we actually spoke to a lot of the regeneration. This is called regenerative medicine researchers in and out of the areas of Parkinson's disease, things like CRISPR gene editing, stem cell therapies, next generation stem cells, like what Nick was alluding to. And one of the things that I found very interesting was that a lot of the regeneration researchers have begun to pivot and say, well, we know Parkinson is caused by more than just dopamine. So now if we replace the dopamine, it hasn't cured the disease. So I think that was the biggest, sort of epiphany moment for a lot of people in the last 2 decades was, oh, let's just replace the dopamine with stem cells and Parkinson will go away. It didn't happen, and we can do it, as Nick said. But what researchers have said, well, how about if we adjust our thinking a little bit and we look at a specific symptom that some of the therapies are not addressing. And so one of those symptoms has been memory and thinking dysfunction. And so a lot of the regenerative researchers are now looking at specific areas within the brain to say, well, maybe if we go after, and there's an area called the nucleus bisalis of Meinert is like one, and it's connected. It has a whole bunch of different connections. And they thought, well, maybe if we start to use some of these stem cells in some of these areas, we could stamp out a symptom that is really important to people, and that's memory and thinking. And so I think you're going to see some nuance and some changes about how we're thinking about stem cells. And the last point that we learned from interviewing folks was that stem cells can be put into a dish, and that sounds like old-fashioned, but actually now people are growing what are called mini brains in a dish. They're called organoids, and many people refer to them as mini brains in a dish. And you can put a bunch of these many brains together, and they may be able to recapitulate or look like what happens in the human form better than we thought before. And so these stem cells that Nick was talking about are actually proving to be much more valuable right now to researchers trying to answer the why questions. Why are we getting Parkinson? What's going on that's causing it? And so, so just a way to kind of rethink and reframe.
Thank you. Okay, the next question is orthostatic hypotension common? And what's the best treatment? So orthostatic hypotension refers to a problem where when a person gets up suddenly, either from laying to sitting or standing, within a minute or so, they get kind of dizzy or woozy or lightheaded. And that has to do with sudden drops in their blood pressure. And this is very common in Parkinson's, and sometimes it's a secret cause of falling. If you notice, you always fall in the first few minutes after getting up. This could be part of the problem. Very common in Parkinson's, especially the longer a person has Parkinson's. So the best treatment, first of all, number 1, 2, and 3 is to make sure you're drinking more water, hydrating. And I think of it as like if you ever tried to water a garden with a hose and didn't turn up the hose enough, the water wouldn't get through to the other end. So we have to have enough in the pipes to get it where it needs to go. So water. The next thing is you can be a little more liberal with your salt intake. So most doctors tell you no salt, low salt, but this is a problem that actually does better with a little more salt in the diet because it keeps the fluid in the blood vessels. And the other thing is we have to look at your medicine list because some medicines are good at aggravating this. And sometimes we can move things around in a way that lowers the chance of this problem. And finally, we have actually one more thing. There are compressive stockings you can wear or an abdominal binder, which give a little bit of a squeeze that help this circulation problem. Before you get up out of bed in the morning, it's a good idea to sit for a minute before you stand. And you can even squeeze your knees to your chest a little bit, and that can help this problem. Finally, there are 4 medicines that we use to help this problem. Their names are midodrine, fludrocortisone, pyridostigmine, and droxidopa. But there are 4 medicines we can prescribe that work in slightly different ways to reduce this problem. So it's very treatable and very important problem.
Sure. Do you find, is there a correlation between paraquat and TCE exposure and young onset Parkinsonism and death? So we showed you that 80% of people who have young onset Parkinson's below age of 50 have nothing to do with genes. Even if your onset is below the age of 30, 70% have nothing to do with genes. So I think it stands to reason that environmental chemicals, including paraquat and TCE, are linked to it. You know, the most famous person with young onset Parkinson's is Michael J. Fox. And so this is public information. He was part of a cluster of individuals on one of his early TV shows before Family Ties, where 4 of the 100 people working on that TV show developed Parkinson's disease, suggesting an environmental exposure. He recently told Jane Pauley that he thinks he got Parkinson's from exposure to some kind of chemical. And then the other side is he's lived a very long life. He's over 30 years into his Parkinson's. So although Parkinson's has a moderate increase in mortality, people can live very long lives. You can star in TV shows. You can get a PhD. You can serve in Congress. You can serve in the Senate. You can be the head of the Catholic Church. You can walk in space. You can do lots of things, and people with Parkinson's have done all of those things. So as you all know, Parkinson's is far from a death sentence. People can live highly productive lives with this disease, but fundamentally, we're talking about a disease that is preventable and that people can live lives free of this disease. And I can't think of a better gift.
Okay, I'm going to try to answer 2 here because they, I think, are on the more quicker side. One question was, how do we recruit movement disorder specialists to our area? So this is a challenging one. I think this is something that Parkinson's disease patients around the country sort of struggle with. For the most part, movement disorder specialists will tend to cluster at academic centers. So if you don't have a large academic center, finding a movement disorder specialist in private practice can be a little bit challenging. There's nothing specific that I could mention that you could do to recruit a movement disorder specialist to the area, with the exception of potentially talking to the local hospital and trying to get them to realize the importance of having a movement disorder specialist. That might help them to recruit. But even if they had an open recruitment, it's difficult to get to find movement disorders neurologists because there just aren't that many of us. One other question. Someone had written in the night around 3 a.m., they are experiencing unrestful sleep and then nightmare starts, and they take an extended dopamine, extended release Cinemet when they go to sleep. Any ideas would be appreciated. So obviously sleep issues are significant and part of the non-motor issues of Parkinson's disease. You would need to get a full evaluation to get a specific answer, but one thing that people could consider doing in this situation, if they're finding that around 3 o'clock in the morning, they're having a sudden waking up, they may be acting out their dreams. So REM sleep behavior disorder is common in Parkinson's disease. Sometimes it can even precede the motor symptoms of the disease. And so melatonin can sometimes be helpful at bedtime. I usually recommend at least 6 milligrams, and that can sometimes control some of the movements that would wake someone up during sleep.
All right. I have a question regarding my talk. It says, are Crexont and Vyalev available at UF Health? So Crexont is the newly approved drug that I mentioned, the combination of carbidopa, levodopa, extended release, and then Vyalev is the subcutaneous infusion pump for carbidopa, levodopa. So the short answer is yes, those therapies are available at UF. And the long answer is that there are some conditions. So for the Crexont, like I said, it's new. So we're still kind of trying to work out what steps the insurance companies want us to take before they're willing to cover this medication, and what kinds of resources we have available if the insurance is hesitant to cover them. So we're still kind of working out exactly how that works for people on different insurances. But I will say that we have several people in our clinic who have started it, and some people really like it. So that one is available. But as I mentioned in my presentation, usually that's something that will kind of progress to, given the insurance constraints, after people have given a good trial of some of the immediate release, Cinemet, or the controlled release, maybe a couple other different medication options too. And then regarding the Vyalev, we're still kind of working out how that process is going to look in our clinic, but we've been trying to get a couple people started on that. As I mentioned in my talk as well, there are a few requirements and kind of qualifications that people have to meet to qualify for this under insurance plans. One of them is you have to be 65 years of age or 63 years of age or younger and be on a commercial insurance that is not a Medicare insurance. And that's going to be the case at least for a few more months, but they're working on getting Medicare coverage as well, and that might open up the age range that's available to people. These people need to respond to oral carbidopa, levodopa, so have some symptom improvement. And they have to have at least 2.5 hours of off time per day to qualify for that. So there's a few conditions, but the short answer is we do offer them at UF.
In case anyone doesn't know what's Vyalev, that's carbidopa, levodopa subcutaneous infusion. So that's the pump that goes under the skin.
All right, I have someone asking, does Parkinson's continue to be more prevalent in men compared to women? Are there any changes? And by the numbers, yes, it's more common in men in the United States. But just last night, Dr. Dorsey was telling us that depending on who you ask, in different countries, it's more common. For example, in Japan, it's more common in women. In some Latin American countries, it's more common in women. Some of them more common in men. So if you average it out or over the years, it's probably about the same prevalence, both in men and women. The difference between men and women, is, as I was telling you a few minutes ago, was that we have increasingly recognized that Parkinson's may present slightly different in women, especially when it starts. Women more often present with focal dystonia, or things that are not the tremor, the stiffness, the slowness that is traditional. So over the years, we've been increasingly recognizing that more as Parkinson's. So it used to take longer for us to figure it out that women started to have Parkinson's, but now it's starting to change. A good analogy for this is when heart attacks in the 80s and 90s, that we used to think that almost only men had them. But then we figured out that in women more commonly have a typical presentations where they will have like stomach pain rather than chest pain. And we used to think that was indigestion, but no, it's just an atypical form of a heart attack. So over the years, we've been able to recognize it more. But in reality, it averages out to about the same.
Answer. So we have 3 more questions. I also want to thank everyone who's watching virtually. And some of these questions actually came from our virtual audience at home watching on Zoom. So this question is there a best time to take medication? What if you're told to take it twice a day, for instance? So an excellent and important question on timing of medication. Definitely something you want to work out with your healthcare team because it's very different one person to the next. The kind of general influences of the best timing have to do with spreading it appropriately across your day so that you have continuous control of your symptoms. The longer we have Parkinson's disease, there are more changes in our brain so that our brain is less able to hang on to that medicine and benefit from it for more hours. And we need to take it more frequently and sometimes at higher dose the longer we have it. There are some factors that can be important. For instance, when do you wake up? When do you go to bed? When do you eat your meals? And what are your activities? If you love to golf, which is important to probably several people in the room, sometimes we want to make sure that you're at your best benefit during that time that you want to be active. Sometimes we'll even fine tune a certain dose to be a little higher because we know you have activities. The other thing has to do with meals. If your Parkinson's symptoms are mild and you haven't had it for very long, we might tell you to take your medicine with food because you'll remember to take it and it helps you not get an upset stomach. But if your symptoms are not easy to control or you've had it a long time, sometimes we want to time the medicine away from the meals because for some people, the food absorbing of the food interferes with absorbing of the medicine, and they might feel like their food makes their medicine not work as well. So there are a lot of different factors, and how you do when you come back and tell us, hey, I feel great, but then 30 minutes before my next dose, I start to feel bad again. That would change the timing that we might tell you to take it. So it's different for each person. If you're only taking it twice a day, which is probably unusual, you're probably going to take one in the very beginning when you wake up and one maybe around dinner time if you're only doing it twice a day, but that's unusual. So make sure you talk with your doctor or healthcare provider to sort of sort that out.
All right, and then we have another question about DBS here saying, what considerations and issues going from unilateral DBS to bilateral DBS? And so this is a really great question, and a lot of it will depend kind of on the center that you have your DBS surgery performed at, because where we are, we typically like to do a staged surgery. So we'll start with one side of the body and then we'll go to the other side after some time and after we've optimized the settings for the first side. With other centers, sometimes they'll place both of the sides at the same time. And so when we are looking at side effects, the things that we see an increase in when we're going from one side to the other to having both is that we can see increases in dysarthria. We can see increases in balance issues. Yep. And that's the feelings of kind of like talking almost like you're drunk, a little bit of slowed speech, clumsy speech, things like that. Those are the symptoms that we typically see a little bit of an increase in when we go from unilateral to bilateral. And a lot of times we can adjust the stimulation to try to get away from some of those symptoms, but we definitely will notice that can be something that pops up.
Okay, and the final question is for Dr. Dorsey.
Thank you very much. So the question asks about inconsistencies between data on environmental exposures and Parkinson's. So I showed you a map that showed areas of the country with high rates of air pollution had high rates of Parkinson's. and low rates of air pollution, low rates of Parkinson's. But there are obviously some inconsistencies. And it really shows how difficult these studies are to be done. So, for example, many people, the exposure that might be relevant is when you were young. So many of you shared with me your stories. Many of your exposures when you were 18, 19 years old. Some of you had exposures with children. If we mapped you all to Florida and you had Parkinson's or not have Parkinson's, the relevant exposure may have nothing to do with the environment of Florida. It may have been the environment that you had when you grew up in Ohio or Turkey or wherever you grew up. I'll just point out, you saw some great data especially from the fellows that were from randomized controlled trials. And they showed randomized controlled trials for focused ultrasound, for DBS. And those studies are all controlled. And so that's why you get really good answers as to whether DBS works or doesn't work, whether focused ultrasound works or doesn't work, why a certain formulation of levodopa works or doesn't work, because you can answer that question in a controlled study. And you can, from that, reach a conclusion about causation. For environmental, we don't randomize people to farm with paraquat or not farm with paraquat, follow them for 50 years, and then see who develops Parkinson's disease, right? Not ethical, not feasible, be really costly to do so. So like really one of the great studies is this Camp Lejeune study. So I'll show just some difficulties with the Camp Lejeune study. So Dr. Hess here was actually served at Camp Lejeune after the chemical was cleaned up. But they followed these individuals from the 1970s and then looked at Parkinson's 30 to 40 years later. So one, you have to find a cohort. Then you have to find a comparison group. So they found a comparison group of people who served at Camp Pendleton and followed them forward. Well, a couple things. One, Camp Pendleton was also contaminated with TCE, but less so than Camp Lejeune. So that biases your results to be understated, right? Second, if someone from Camp Lejeune died of cancer before they got Parkinson's disease, they would never be counted as getting Parkinson's disease. Next, if they were misdiagnosed, they didn't get their diagnosis correctly, and many of you have been misdiagnosed with your Parkinson's disease or had a delay in your diagnosis, that understates the results of the disease. Third, these were all based on claims data. They didn't actually examine the individual, so they relied on claims. You know, when we fill out the form, when you get checked out, we circle you have Parkinson's disease. Well, if we circle the wrong thing, and sometimes we make the wrong diagnosis, that will also biases you to understating the results. So even in a study done by the best epidemiologists in Parkinson's in the world with a well-defined cohort, you still have almost everything stacked against finding a relationship. Almost everything is stacked against you determining that this chemical causes the disease. So when you see a 70% increased risk or a 500% increased risk, you need to sit up, pay attention, because that's probably understating what the true effect is. And so many of these things we just miss because it's really, 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 really difficult to do so. So I'll demonstrate. How many people now think that they know what might have caused their Parkinson's disease? How many people think had some Parkinson's disease, right? So we have about 10 hands. When we started this thing this morning, we had 2 hands. So just from the span of just one day's worth of thing, we've identified causes of the disease. But you guys are all hyper educated. You're seeing Dr. Oak and you're seeing all these great physicians here, and you didn't know what was causing your Parkinson's, and now you know. So just think about how difficult it is, and then pay really, 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 really close attention when they find a link between an environmental exposure and a disease, especially when that link makes sense as to why it might be causing the disease.
So we just had 3 more questions brought up to us from the virtual audience. I think you'll find them interesting.
So it's a question, not so much a question as 2 words with a question mark: vibration gloves. So the story of vibration in Parkinson is one that's been around here for a few hundred years. There was a very famous neurologist called Professor Charcot who practiced in a women's hospital called the Salpêtrière in Paris, and people would roll up in their carriages to see the professor from all over the world. And when they got out of the carriages, he would note that many of them felt like their Parkinson's symptoms had gotten better, potentially from the shaking of the carriage ride over the roads which were not paved. And so, he built vibration helmets, and there's been a whole group of folks for a long time interested in could vibration be a potential treatment for Parkinson's. The answers to this have been mixed, and there probably are some mild benefits from vibration, so there's probably something to it. There's a researcher at Stanford called Peter Tass, who is a physiology type of researcher who's been interested in the oscillations in the brain and how when you apply vibrations, it changes the oscillations in the brain. And he had some gloves that were, some people were on the Today Show showing they're wearing the gloves and felt like the gloves improved their Parkinson disease. Getting back to Dr. Dorsey's comments, none of those studies were controlled. There were no controls on the studies, and then there have been other devices like Dr. Hess and Dr. Helmuth and Dr. Bloom and colleagues in the Netherlands just tested one of those vibration devices and published on it, and it did not show in a controlled study across the group, across the cohort, that it improved folks. They're usually not harmful. As treatments, they're not particularly robust, but there might be something mildly to these things. But when you see them, be a little bit cautious. I remember getting a letter from somebody who was on one of the TV shows that was interviewed about one of these types of therapies that's being asked about, and them saying, "Oh, I read your blog, and then after I read the blog, I realized I was so excited to be on the X show," which was, a nationally syndicated show, that maybe I overestimated to the people how great this therapy was, and I realized it probably wasn't as good as I thought it was. And so I think waiting for good studies is an important thing. In this case, most of these things aren't going to hurt you. They might hurt your pocketbook, but unlike stem cells, we now think some of those therapies, if you try them, could actually hurt you. So I think we always have to keep an open mind, also think about where the evidence is. In vibration, probably some mild benefits, or maybe some people that benefit from it more than others, and probably safe, but not as maybe robust as we'd like. Too much talk for a two-word question, huh?
Quick question.
This was another quick question that got asked with focused ultrasound or DBS okay for pacemakers. And so DBS is perfectly fine for pacemakers. Focused ultrasound, it depends only if their pacemaker is MRI approved. If your pacemaker is MRI approved, then focused ultrasound is okay. But because you have to be in the MRI, it's gotta work in the MRI.
So we get the last question is a three-part question. So I'm going to do this with my big brother Michael. Some questions about global. So what other countries are leading or at the forefront of Parkinson's disease research and treatment? You interviewed lots of experts for our book from around the world. What'd you find?
Well, I was actually really impressed with the quality of scientists across the globe that are really digging in on this. And we spoke to people on every continent except for Antarctica, and it was a little too cold for us to go there. And we definitely saw leading researchers across Europe, multiple countries across Europe, Britain, the Netherlands, Germany, Austria, Italy, some really nice research coming out of those areas. Some nice research coming all the way across out of Australia. But also lots of really interesting things happening in Malaysia, happening in Indonesia. A lot of researchers now doing good work in China. So I, was very impressed, and then a whole bunch of people in South America. And then you see a whole bunch of our fellows here up with us now that are going to be graduating, and we put over 100 fellows out that are all over the world. And so I think there's quality people, and we have had folks say to us, "Hey, I want to go on vacation with my Parkinson. Where should I go?" And I often say, "Well, we probably have a fellow there at one of those countries in case you get into trouble and need some medications," which happens every once in a while.
And then, Michael, are there any other countries that are ahead of the U.S. in terms of collaborative Parkinson's disease treatment? Are these countries that have more Parkinson's specialists? Maybe you'll say a word about our good friend and colleague, Dr. Boss Bloom.
Yeah, so per capita, Parkinson specialists are like an endangered species. If you know that the endangered species list, if they had one for doctors, Parkinson specialists would be on that list. Train about 40 to 50 a year within the North American, regions, and then across Europe and other areas, people sort of tend to go into these areas, but a lot of times there aren't even specific training programs beyond things like neurology, psychiatry, geriatric medicine, and so it's a real problem given the challenges that were outlined by Dr. Dorsey in terms of the growth rates that we're not investing in these things. We certainly have invested in tons of cardiologists all over the world, and you've seen that with all the different studies that have been done on heart disease and everything, and it's made a difference, in Framingham study Ray and I were talking about yesterday, and all the things that we learned about high blood pressure, and stroke, and heart attacks. But what really is focusing our communities now, the focus should be on the growth of neurodegenerative disease. One of the countries that does stand out is we have a good friend named Boston Bloom, who was a co-author on the Ending Parkinson Disease book. They do outstanding care throughout the Netherlands. We often hear people say, I'd like to take my vacation to the Netherlands because I know they have Parkinson specialists in every one of their provinces. It's about 20 million people. So it's about the population of Florida, but in a different shape there, maybe with 2 or 3 more windmills than we have, and a little bit more dense across that. But they have put specialists and specialty teams across the entire area. Most countries are struggling, and so we're not alone. And the World Health Organization has put together a number of different panels. Even recently, we were part of the 6 or 8 action steps for Parkinson's disease.
And then the last question is, if you were a single 50-year-old individual with Parkinson's disease and could move to any other country, where would you go? So actually in our book, if you have means, we make you consider where you live and where you work. The health you have today is a reflection of your environment, not so much your current environment, but your past environment. That said, there's increasing evidence that, for example, air pollution is harmful for people with Parkinson's disease. And there have been studies in Los Angeles that have followed 70-year-old women who were cognitively normal, and women who lived in heavily polluted areas of Los Angeles had greater cognitive decline than women who lived in less polluted areas of Southern California. So I would give thought as to where I lived. I'd give a lot of thought to air pollution exposure. I'd give a lot of consideration to pesticide exposure. There have been studies linking golf courses, for example, to proximity golf courses to Parkinson's disease, at least in case reports. We talk a lot about avoiding dry cleaners and the like. So I would give a lot of thought. Well water and testing your water, for example, I would give a lot of thought to my environment for your health today and your health tomorrow. And I would do that also for your children and your grandchildren, because their environment that they have right now might dictate whether they develop diseases like Parkinson's and Alzheimer's generations later.
So again, we thank Dr. Dorsey for coming to be with us today. We thank all of you for being here today, including our virtual friends that are watching us over the computer. If you have any thoughts about talks that you really loved or talks you'd like to hear next year, you can let me, Amanda, or any of us know, and we constantly try to incorporate what we hear from you. So thank you so much and enjoy the rest of your day.